So today, it's not about insurance games. It's not about gaming the system. It's about creating one, making sure that you have your documentation right, and staying out of trouble.
And watch me educate. Yeah, we been could've started, but it's never late. Do it for my kids, yeah, let's set it straight. Do it for your kids, gotta set it straight. It's time to regulate. We need change now. We need solar, we need...
Welcome back to the podcast. Today's guest is Christine Taxin. If dental insurance has ever felt like a system that quietly controls your revenue, increases your stress, and your liability, this conversation matters. Christine is a nationally recognized leader in lecturing and continuing education events for dental and medical billing. She teaches more than just that, though. She teaches compliance, documentation, and how to keep out of trouble. So today, it's not about insurance games. It's not about gaming the system. It's about creating one, making sure that you have your documentation right, and staying out of trouble. But most importantly, gosh, getting paid is nice too.
Yeah.
Christine, how are you doing today? Thank you for coming to the podcast. Welcome to the studio.
Well, thank you. And I'm so excited to be here. I love working with you for so long and having you as a friend afterwards. And it just is a comfortable atmosphere. But I am impressed, Chris.
Well, this is your first time out to the studio.
Yeah.
We've built something I think is pretty special here.
It is.
Were you comfortable in the guest suite last night?
Oh, yeah. It was great. I mean, I can't even tell the future speakers that are coming what a host you are.
Hopefully the peacocks didn't keep you up too much.
No.
This morning.
Yeah.
So today we're going to talk a little bit, Christine, about where did you come from, and then we're going to kind of cover the things that you do in the business of dentistry and how you fit into kind of the schema of how practices operate or how they should operate. But whenever we do these podcasts, I always like to talk a little bit about the person behind the product or behind the company. So talk to us a little bit about you. I mean, where were you born?
Oh, I was born in the Bronx. My father was a first-generation immigrant, so I'm first-generation American, which is kind of cool. And my mom and my father were married over 50-something years before they started to pass. I have a brother and I have a sister. And now I have an amazing husband, 5 children, and lots of grandkids that keep me busy, on top of the work I do. So that's basically my background. And my father was an uneducated man because he came here when he was a child, and his focus on us as children was education. But he always told us to do what we wanted, because the education then would be worth it and give you what you want and make you happy. And I started to work in a dental office when I was like 15, the corner dentist, things were different then.
Gosh,
no insurance, a little card for...
No gloves,
no, nothing. The dark room where you fainted the first time you went in it. And, but I loved it. I just loved it.
For anyone who's never actually developed film or processed it, the odors in the dark room could be pretty overwhelming.
Oh yeah, it was overwhelming. In fact, dentistry itself had a particular aroma. I'll be nice about it. Aroma. Well, you don't have that anymore at all.
Well, they kind of do. A lot of offices still use eugenol. It's actually one of the things that, for many reasons, both clinical and psychological, that I outlawed in my practice. We did not use eugenol at all because the scent of clove, we cache memories with different sensations, sounds, tastes, smells. And the dental office has its own sounds and smells and even taste. If you think about fluoridated, dentifrices and things like that.
Right.
They've got that kind of a bitter taste. So the more things you can do to remove people from preconceived notions and deep deep psychological connections to things that you want to reform. You want to make good connections.
Yeah.
And honestly, that applies to what you do as well, because I think a lot of people out there, a lot of dentists, they look at insurance, and I've been guilty of this myself, and they look at the insurance companies and they're like, well, these are the enemies, and they're beating us up and this and that and the other. But the truth is it's all a game, and there are rules. And if you know what the rules are, then you can win the game.
Absolutely.
That's pretty much what it comes down to. We have to change those preconceived notions. And that's kind of what you do whenever you teach.
Yeah, I do, because there are people, many doctors, including my own husband, who really didn't ever want to deal with insurance, but they almost feel like obligated when they first start for whatever preconceived thing it is. They think they're going to get more patients. And
well, they will, but each one of those patients is going to pay them less, and there reaches a point of diminishing returns.
Right, but it's a starting point, right? I'm not against accepting insurance, but I do teach that being in network is not the only way to work. I'm a big believer in helping your patients obtain whatever benefits they have without having myself to take a loss.
Right, absolutely. The way I told them is it's our duty and our obligation to get you every cent that your insurance company owes you. Now, we can't control their rules, and we can't control whether or not they're going to meet their obligations.
Right.
But for you, we're your advocate to make sure you get every penny back that you put into them. And that, to me, reframed the conversation so that the patient began thinking of their insurance as something they were responsible for rather than something that the dentist was responsible to.
Right. And that's exactly what I try to teach the teams that attend my meetings. This is not your insurance. This is the patient's insurance. So have a little conversation with them, first on the phone. Don't make it where it's a question of, do you accept this plan? Like, move away from those discussions and let them know that you're going to help them achieve the most financial benefit that you could get them. Period. That's it. That's what you could do. You can't cheat for it. You can't do some of the things even patients ask you to do. So, and never say it's a policy. It's not a policy. There are actual laws in place.
I used to like to tell my patients when they would ask things like that, some of them are simply dishonest people.
Yeah.
But some of them just have never thought about it. And so one of the phrases I would use was, well, I could do that, but that would be breaking the law. How comfortable would you be with me as your medical provider if you knew that I was willing to lie, cheat, steal, and break the law so that I could get paid?
That's a great line. Well, I would tell patients, I don't look good in orange. So
it's the hair, it clashes.
It just doesn't do me any good. I look horrible, and I'm not willing to wear it.
So talk to me a little bit about how you ended up focusing your career on educating people about dental insurance and medical insurance billing. How did you grow into that role? Talk to me a little bit about that.
Well, I worked in dentistry, as I said, before insurance came into play. And then I decided I wanted to increase my knowledge, and I started taking courses in billing, and I obtained a job for the chief of spine surgery at Mount Sinai. I loved it. And I just kept growing because Mount Sinai offered education for your position. And the more I grew in certain ways at Mount Sinai, I was getting more and more education, and I was learning so much more. But then our daughter was sick, and she started taking all these medications, and she was losing teeth or needing root canals. And the dentist that was by the facility called my husband, and he said, "Do you have dental insurance?" And my husband laughed. He thought somebody was playing a joke. And he said, "No, I'm her dental insurance." Because she was in a facility for a while with young adults. And every single one of them have the same problems. And it's sad because we always think of meth mouth as a drug, an illicit drug.
It's a biological response is what it is.
Yes, and it's not. It's from medication. And it doesn't matter how old you are. A lot of medication dries your oral cavity. And there are also, the factors of this medication and not taking care of yourself correctly at certain times in your life. And so I decided I was going to be on a mission. So I joined a group called NAMBI, which is Parents for Children with Disabilities. And I couldn't believe how many parents couldn't afford to get this treatment done. So I started billing medical for it. And I saw patients that needed so much work that were able to get it, which changed their mindset into wanting to be better.
Well, and that's an interesting point of view. And correct me if I'm wrong. What engendered you beginning to do medical billing for dentistry, I mean, other than you have the background
right.
and your husband was a dentist, is you actually saw this in a different light than perhaps other people do. You saw this as a complication due to a medical procedure as opposed to an oral health issue that was separate and apart from the other health procedures that were there.
Yes. I think it was really my first time thinking that the body is affecting the oral cavity because we were told it wasn't connected for so long. And so I really did a lot of work, and I went to Buffalo and studied under Dr. Jenko, who was like the guru of oral systemic at that time. And when my son decided he wanted to be a dentist, I said, "You're not going to go to dental school until you do a year of study with biology with Dr. Jenko." And he did. And he is better for it because a lot of this connection hasn't been taught in the dental schools. It's getting better, but it's still not the big focus, and it should be.
Well, the great rebuff, right?
Yeah.
Something I know you're very knowledgeable about, but something some of our viewers may not be, is the fact that dentistry was supposed to be a part of medicine. But basically the MDs looked at the dentists and said, "Oh, you guys used to just be barbers. You're not even really a real science." And truthfully, at the time, it wasn't, but neither was medical, truthfully. It was really in its rudimentary form at that time. And so the dentist said, "Okay, well, screw you. I'm taking my ball and going home." And it has been the same way ever since. So we treat the mouth as not really a part of the body. Us and podiatrists, right?
Yeah. But the funny thing is now the doctors have online, the medical providers, family practices, and many, many surgeons and things are now learning to look in the oral cavity and to refer the patient for treatment. So I got called about 6 years ago to go to Detroit Medical Center, and they wanted to set up a clinic within the hospital because the surgeons that were getting this training said, "Well, then we don't want to operate unless their oral cavity is clean because let's put the cards on the table. Everybody has to worry about malpractice." So I was fortunate enough to be the one that went there, and we instituted an in-house dental program. So these patients that were coming in and needed whatever kind of surgery were getting dental treatment before the surgery, whether they were in the hospital already or before they were admitted.
I imagine your outcomes on those surgeries had a much lower incidence of side effects or, secondary nosocomial infections.
Well, it did prevent that one big thing the most. Infections after surgery.
Right.
Which is a big complication for every patient.
Well, I mean, if you think about it, you're going into a situation that's stressful to begin with, that reduces your immune system because it increases your cortisol levels. So you're going to be in a place that is filled with bacteria that have come into contact with antibiotics of all stripe. So there are going to be some resistant bugs. And if you're already going in with a bacterial load that's stressing your system, you are going to be more likely to get something else.
Yeah. Well, now we're in the world of this is happening where we can prevent a lot of these things. And we have to start. The fall of dentistry is not about money. There's going to be money. The money is there. I mean, I'm getting paid, $80,000, $90,000 a claim for a patient that needs bone grafts and things like that. But that's not really my focus. My focus is getting the patient healthy. Because why should we live less years than other countries who are doing this already? Like Germany, one of my friends that is a German MBA said, dentists and doctors train together. They're at the same hospital. They're at the same school. And they collaborate all the time. And when I got to teach at Harvard, I was shocked. I knew they had a program that they collaborated. The first year of dental school and medical school, they worked together. But they called me to educate on the changes in the medical billing. But I thought I was teaching the students. No, I was teaching the faculty because they were arguing with the students when they came back to the dental side. And
doesn't surprise me.
Yeah, and people feel like, well, this is what I know and this is what I do. And I say that about billing too and about running a practice. It's hand-me-down information. Nobody that works in your practice besides the doctor and my hygienist went to school. Assistants get some training, but the people that are handling your patients on a day-to-day basis, the people that are billing for you, they have hand-me-down training. Why would we not want to invest in these people?
It's always reminded me of an old joke. Are you familiar with the joke about the pot roast?
No.
Lady is cooking in the kitchen, and her daughter says, "Mom, why do you cut the end off of the pot roast like that?" She said, "Well, I've never really thought about it. This is the way my mom taught me to do it, and so I've just always done it that way. Maybe it makes the pot roast more tender. And the daughter says, "Well, that just doesn't make any sense to me." So the mom starts thinking about it. She calls her mom. She says, "Mom, why do we cut the ends off the pot roast?" Mom says, "Well, I don't know. It's just always the way it was done. My mom taught me how to cook a pot roast. We always cut the end off." And she said, "Well, let me call my mom and find out." So she calls her mom. She says, "Well, Mom, why did we cut the end off the pot roast?" And her mom said, "Well, the pan was too short." We teach these things as if they're facts. We teach them as if they're settled. But in many cases, it's like you said, it's just hand-me-down information where one person learned how to do something and they've never gotten in trouble. And so they teach it to someone else and they don't get in trouble. And they teach it to someone else. It's been wrong the entire time.
Yeah.
But the insurance just isn't catching it and they're not checking up on it. But in today's world, they're much more litigious. They're looking for ways to get you. They're looking for ways to not pay you. So it really behooves you to go back, take a step back and say, was I taught wrong? Is this really the right information, whether it has worked or not?
Yeah. And don't forget, the insurance companies, they're not really looking to hand out the money.
No.
So they're making money by keeping it, right? I mean, everybody knows that. But the reason they change contracts, the reason they change things is so that they can get more money back. So this year alone, and I'm just not even going to go backwards because it's every year, but this year alone, the new dental codes that are coming out, half of them are only billable to medical. Mm-hmm. There is none of them on the dental contracts. So that means that more income from the patient has to be paid. And of course, they're going to pay your full fee because there is no insurance. But they have no way of having the work. What I have found with medical billing is look in your treatment plans that haven't been accepted. Mm-hmm. It's always big treatment. It's never a filling or a cleaning or any of those things. It's always the bigger work because it's financially stressful on a family.
Well, it makes a roadblock.
Right. And I'll tell them, pull out one. Just pull out one. And let's say if we could call the medical insurance for this patient and get a pre-approval on the treatment you need. And every single time I get a call from an office saying, oh my God, I did what you said at the meeting and I got it pre-approved. And I said, okay, be careful now. Remember this, pre-approval is not a guarantee of service. So that's the next step in your treatment planning. Mm-hmm. Make sure that the patient sees that EOB, reads that, highlighted in yellow, and signs it so that they understand that you have no control after this point because there is no pre-treatment that's a guarantee.
Absolutely. So I like to tell people that it's not because the insurance companies are evil.
No.
It is simply their business model.
Their business.
But you have to understand their business model. And I'm going to be very frank. If you are a dentist, if you're a patient, if you're a hygienist, an assistant, what have you, I want you to listen very carefully to what I'm about to say. When you're an adult, you have 32 natural teeth, unless, of course, you have hyperdontia or hypodontia or something else like that, right? Let's just say average person has 32 teeth. Now, 4 of those teeth, your wisdom teeth, in general, because of our American diet and because of our genetics here, simply don't usually fit within the jaw well. It doesn't mean it's got to happen, but in most cases, we're going to say, let's go ahead and remove those wisdom teeth to make sure we have enough room for cleansing the others and we can keep them safe. Never had an insurance deny those extractions. So, dental insurance companies are in the business of risk mitigation, okay? They mitigate risk by removing things that will become expensive later. So in my entire practice, I have never had an insurance company not pay for an extraction, ever. They may downgrade an extraction. They may question whether it was a surgical extraction, but they have never not paid one. So let me talk about why. Whenever you extract a tooth, you remove a risk. When you remove a risk, you remove liability for the insurance company. A dental insurance's absolute avatar, their perfect customer, is a person who has one healthy tooth in their mouth and is still willing to pay the premium on their insurance policy to keep that tooth healthy. I'm going to repeat that. A dental insurance company's perfect patient has one healthy tooth and they really want to keep it bad. That is the truth. There's no good, there's no evil in that story. That is simply the way that things are. And so you as a provider and you as a patient need to understand your actual relationship with that dental insurance company so that you can navigate these discussions and these claims in the correct manner.
Yes. And let's not forget that they also have companies now. So they pay out that claim for whatever they pay. And they have 7 years to go over those claims and take money back.
Not in Texas, baby. And you're welcome if you're in Texas, because I passed that. So, did you ever get a chance to read through my insurance portals bill and all the stuff? You got done with that?
Yes, and that is happening, but not fast enough.
No, gosh, not fast enough. And
across the country. I mean, it is, and it's one of my pet peeves of getting things done. It's difficult when you don't have backing. Mm-hmm. I just wrote a letter to every insurance commissioner of the country, okay? Mm-hmm. Because I also have a billing company, and I always step in a little bit just to keep up with what's happening on the phones, what's happening. Because, it does take longer to pre-authorize than it does to bill, okay? You can't get a live person anymore.
No.
At all. For years, but it's even worse with AI. AI can only answer what they've been trained to answer, or they hang up on you. Mm-hmm. So I wrote this letter to every insurance commissioner, and I said, we have an obligation to our patients, you included as the insurance commissioner. Patients don't understand their insurance. In fact, when my mother and father were both ill, do you think they understood their insurance? And Medicare is not easy to even understand. Making sure they got the coverage they needed, the medication they needed, was a full-time job for me. Mm. And I decided that it was time. After this one phone call with AI, I blew my gasket and I said, I'm going to call every insurance commissioner. And I said, well, that's going to take too long. So I wrote the same letter to all of them, and I CC'd every state. And I said, this is time for you guys to step up to the plate, because doctors cannot do this. This is a full-time 5-person job in some instances, according to what you're treating, of course, because there is so much blockage. Yeah, it's the patient's insurance, but the patient doesn't even know what to say or ask for. So they ask us to do it, and we can't get the same information they can get. Mm. And we're speaking to a robot now, which is useless.
Absolutely. And to be very honest, whenever I wrote the bill, it was one of the consequences that I foresaw, because the insurance companies were fighting us on it. And the way that I got them to come around to it was by actually mathing out the amount of money that they would save on having to answer questions on the phone. And my suspicion was that when they realized how much money that was, they were going to run with it, and they were going to cut down on their human service on the phones. And unfortunately, I was right. So, sorry, guys. Honestly, not something we could have avoided in the text of the bill.
And I think it could be simplified, truly simplified. What is the medical necessity? So we extract teeth, and they won't pay for bone graft. Mm-hmm. So what's the outcome?
Right.
Eventually, they're going to need the bone graft, or they're not going to have any ability or function to chew and swallow, which, by the way, is a diagnostic code. Mm-hmm. So now here you have a patient with diabetes, lost multiple teeth through the years, has no jawbone left, and is going to cost triple the amount of rehabilitation. So why do you think dental stopped paying for that?
There is a have you ever heard of borrow buy die?
No.
So there is a wealth strategy that many of the financial people I talk to teach, which is basically you borrow the money to buy things, houses, whatever. Mm-hmm. Then you turn around, you borrow from that equity and borrow from that equity, and it's really a house of cards. But that is how they teach you to push the ball down the road, kick the can down the road so you don't have to pay those bills, because it's all on borrowed money. And when you die, if you set it up right, no one has to pay for it. So, unfortunately, it's kind of a buy, borrow, die cycle in dentistry. But the person they're hoping dies is the patient. I'm not saying that they're hoping the patient dies, really, but their intention is to delay payment for as long as possible so that people will eventually just stop asking. And so then that problem has died on the vine. They don't have to worry about paying that money anymore. They don't have to worry about paying their people to continue to deny or, answering questions on how I can refile or what have you. Eventually, people just get worn down by the system. And I genuinely believe that is a very intentional choice on their part.
Yeah, for sure. And especially that we advertise that there's shortages in our field in dentistry. There's no education being given to them. And of course, paper piles up because they get a letter from an insurance company, but they're only one person. You don't see that in medical. Mm-hmm. Medical has a different system. It's put together by the office team and billed by the biller and the coder. Mm-hmm. Outside of the office. That's why I'm seeing a growth in outsourcing. The difference is you need to make sure that you're reading that contract, and you need a lawyer to help you make sure you're picking the right company for you.
I agree.
And that could be a downfall, and I've seen that.
I actually recommend that dentists have a lawyer read their insurance contracts.
I agree. That's why they don't know what's in the contract.
Exactly.
But the other big thing is don't listen to what you read in the mail or email, or at one point I remember getting a letter. If you're going to stay in network, do nothing. Well, yeah, they could tell you that, but that's really not what you should do because they change those contracts all the time. Mm-hmm. Don't you want to know what's in it now?
Absolutely. I actually had an insurance company that they called us up and they said they wanted some money back. And I said, well, no. And they said, well, we overpaid you. I said, no, you paid me my fee and we're not network with you. Oh, yes, you are. Mm-hmm. I said, send me the signed contract. Crickets, and I never heard from them again. They will 100% lie to your face because they know. I actually did a report on this not too long ago. 30% of dentists don't know what contracts they're in network with.
Yeah, look at the leasing law. They have.
Well, aside from umbrella plans, and we're going to get into that a little bit and how that's complicated the billing landscape and all. But aside from that part of things, they don't know their primary contracts.
Right.
It's not even about network leasing, and that's insane to me. What business owner doesn't know the mechanism of payment for their business? And that's what insurance is, folks. Insurance is a mechanism of payment, not a mechanism of diagnosis and not a mechanism of treatment. And you need to get that through your head because it's not about what the insurance company pays for. It's about what's right for the patient. And a lot of times you can get the insurance company to pay for what's right for the patient if you know how to put your records together correctly.
Yeah. Well, documentation is
absolutely
a major problem. And when I was teaching at NYU, I'll never forget, the students, and they have to wait for the professor to let them go to the next step. So their notes were humongous, like too much information. But they get to residency, and I go there to teach them at the residency because now they're putting in their own treatment and the computer system and all that stuff. And I said to them, guys, these are text messages. These are useless notes. Mm-hmm. What happened in a year? So they went from a book to a text message. Mm-hmm. And I'm telling you, even dental insurance now is not going to pay you unless it is documented correctly.
Well, I believe that in, 2014 was EHR was mandated I think they drugged that on for a couple of years, if I'm not mistaken. They originally said they were going to fine you like $100,000 if you didn't have an electronic health record. There's still places with paper charts out there that never been fined. And I believe that was it 2018 that they actually began requiring, supposedly, none of us have done it, but they required that you would actually put in soap notes.
Yeah.
But no one does that anymore.
Oh, and that's the major.
Or ever. No one's ever done that.
Yeah.
I did my practice because I was taught better by her. I mean, some of the stuff I already knew, and it was a question I brought to you. It's not hard. All you have to do is write a notes macro to make sure that the relevant information, your subjective, your objective, your assessment, and your plan get put in. And we already do that, guys. You're already saying, hey, look, I took x-rays. I looked in the mouth. The patient said they're in pain. What I saw was this. What the x-ray showed was this. We're going to do a filling on this tooth because I see that there's decay on that tooth. You've got your plan, which is to do a filling. You've got your diagnosis or your assessment, which is they have a cavity. You've got your subjective. The patient says they're in pain. Subjective because even though the patient says it, you can't test it and you can't document that as an actual observation in your practice. So your observations would be your visual observations, your radiographic evidence. We do all this stuff. It's just about putting the note into the computer in the correct fashion.
Yeah. Well, now it's going to be even easier. This is one thing I am happy about. I was asked to be on a project for AI dental billing. And my biggest thing was I had made a template with questions for a soap note. And I trained the team. The person answering the phone has 5 questions, 6 questions, get those answers. The assistant that always brings the patient into the operatory and already is taking x-rays, which, by the way, is a legal diagnostic tool and has to be ordered by the provider, not the front desk, not the assistant. The provider must document, these are the tests I want. And let's look at it this way. If we are going to be incorporating medical, which will pay, it pays, then we have to diagnose better.
So one of the things I think people don't understand is that whenever you make a diagnosis or whenever you make a recommendation for a test or requirement for a test, you have to have a rationale behind that.
Yes.
And a lot of people, they freak out about this, and I may have messed up on this myself, so you can correct me here. But for years, what I did is I actually had a flow chart at the front desk, and I said, please note, these are my standing orders, Dr. Christopher S. Huffpower. If a patient comes in pain, a radiograph must be taken so that the bone level and mineralization content of the tooth can be ascertained. In this instance, a minimum of 1 PA and, if possible, 1 bite wing of the area must be taken. And I signed it. And that is a standing order.
And that is a normal order.
Right.
And you would know that the minute the patient called, and that person can tell the patient, this is what you're going to have done, so that doctor can now have information from his diagnostic test, because people are freak out with x-rays. I don't really understand it, but especially in today's dentistry, it's not like when I first started, and he can't diagnose without it.
Right.
It's impossible.
You can guess.
Well, yeah, but I don't want you guessing on my body. So
I guess the point I'm trying to make there is that this stuff really isn't difficult. And those are the thoughts, whether they're in the same words or not. Every dentist has go through their mind whenever someone says, what should I do with this patient? And you're like, well, gosh, they're hurting. Take an x-ray of the tooth.
Yes.
Okay, so what you're doing there is you're taking your rationale, the things you're already thinking every day. You put it down on paper. And the reason that you print it out and you sign it is because it becomes a standing order. Now, the way that works, and you can elaborate on this, you can either choose to give an order directly to each one of your subordinates, or you can have a standing order that has very specific criterion under which that standing order is executed.
Yes.
Now, the reason I started doing this is because I actually have a couple of friends who are doctors, and they're like, oh, yeah, we just use standing orders. I was like, wait a minute, that's brilliant. I'm going to put standing orders up. I'm going to have a book of workflow that says if this, then, and then I don't have to worry about, did I make sure I said this?
Exactly.
And then my macros would say, per doctor's order, number such and such, this was done.
And that's all you need. They make things complicated.
We make things complicated.
Yes, we make things complicated. And it's streamlining the issues that you could possibly get in trouble with by following that streamline, actually.
So let me ask you a specific question. I had planned to talk to you a little bit about, what did you see early on in doing this that made you realize that dentists were more legally exposed in ways that they didn't understand?
Well, first of all, I've been doing this for 25 years, like immersed. I've had a lot of lawyers call me, a lot of lawsuits, including Medicaid, Medicare, regular insurance.
Lawsuits that she testified for or against, not that she had lodged against.
No, I didn't have it. I was called to help as an expert coda. And I think that one doctor that I in particular had, the FBI came in one morning, took all their computers. That was how they found out they were in trouble. Okay?
Wow.
In all 4 of their practices. So their lawyer recommended getting me and helping them figure out what was wrong. I do work with an amazing gentleman all the time who is a compliance expert and worked for the government taking out those computers. And now he has a private company, and we call him the Tooth Cop because he knows exactly what they're looking for. So, of course, he was my first phone call. And together, we figured out, before they even got told by Medicare, what they found and what they were against.
Well,
90% of it was hygiene-based. The reason it was hygiene-based is they were taking that CBC, the orthogram, and bite wings and billing a full mouth series. Now, the insurance company is now doing that too.
Right, but that's an extra oral rather than intraoral.
Right.
Course.
So it's not really the same thing.
Right. Let's explain that for everyone.
Yeah.
So, guys, here's the deal. There's a lot of CBCTs, and CBCTs, some of them do have software that allows you to reduce the beam hardening and to reposition the radiograph such that it looks like a bite wing and gives most of the information of a bite wing. Now, the issue is that because of the fact that the sensor is on the opposite side of the head rather than intraorally, the way that the data is registered by the sensor is different. So technically, it is a different code than the CDT code. It doesn't mean you don't have the same information. Theoretically, you do. And that's an argument for a different day. But the truth of the matter is the code says intraoral radiograph. This is an extraoral radiograph. And so technically they were guilty of billing fraudulently because they did not bill what they did. And if you guys have talked to me at all on the business of dentistry, I always tell you, I don't care what the insurance pays you, bill and code what you
do.
did. Trust me, they'll let you know if they're going to pay you less.
Yeah. And now the insurance companies are doing that to the doctor's offices. And I tell them, don't accept it. Do not accept it because it's not a full mouth series. So they're asking you to bill incorrectly. So you have to know that it's not the way it should be. And you have a right to, and this is where, listen, when I was working in New York City, in offices. I became friends with the commissioner. That was my goal. I want to know what I could go to you for and what you could help me with when I felt I was being told wrong things. And he would always say, if you know it's wrong, tell them. If they're not listening, write me. So I live by that rule to this day.
So something we should cover. One of the common ways that people use CBCT, obviously we're screening for failed root canals, we're screening for cancers, or we should be. We are specifically screening, depending upon your FOV, your field of view, you may be screening for brain sand, which could be a pineal tumor. But you're also looking for bone levels for implants, failing restorations, things like that. We all know that. A lot of people will pull a panoramic off, and they charge that out as a panoramic, and guess what? You're right, because a panoramic is an x-ray from the outside that is actually columnated data. It's the same exact thing as a CBCT pano. It just goes through a different step in the process, but it's still an extraoral radiograph. And you are completely within your rights to do that. But you cannot do a PA. You cannot do an orthogonal view. You can't do a Waters view. You can't do an intraoral series because it's not. Now, it's possible that some company may make some weird device you can stick inside your mouth and just use the source from the CBCT. And if they did that, then you would be 100% accurate in your coding. But because the source is external to the mouth, as is the sensor, it is not appropriate to code anything that is an intraoral radiograph from a CBCT, no matter what the manufacturer tells you, no matter what anyone tells you.
Yes, I worked with Cable Car selling. I mean, I wasn't selling. They would sell the CBCTs from all the companies. We had big meetings, 2 a year, and I was hired to teach the medical billing. But I worked with the lawyers that were there. I worked with the whole group. And doctors, there are other codes for a CBCT scan. Endo uses those codes because that's what they're using. And so they're using the problem focus area, maybe the lower jaw, the upper jaw, whatever it may be, and they're billing it 2 and 3 times.
Well, there was actually, and that's actually another thing. It is technically correct because the image must be processed to render a panoramic. It is technically correct that you can both bill out a CBCT and a panoramic from the same image. That's not breaking the law.
Right.
Because you're actually forcing the software to create a pano. I believe you can do the same thing for cephalometric.
Yeah.
But there are codes that specify that they're extraoral radiographs.
Right.
And they are meant to be. I could be wrong. Didn't they have a code that they at least. I think that they had discussed putting it into the CDT. I'm not sure if they ever did. It was specifically, if I remember right, a vertical bite wing, but it was a vertical bite wing extraoral source or something like that. Did they ever actually add that?
No. But what I recommend in surgeries or any of that, if you're going to take a CBCT scan, please don't do it for free. But you paid a lot of money for that machine. And if you went to a hospital to get the same CBCT scan, it would be $5,000 when you're not paying.
You're probably charging $350, $375.
Yeah, not even some of them. And that's one thing. That actually diminishes the need for the treatment. You're not selling more treatment because you're doing that for free.
Right.
And I could guarantee that. If I did an audit, I would know 1, 2, 3. Just run a report out of your computer for that code.
Well, you're diminishing perceived value.
Yes.
If something's free, it's not valuable.
So when you start looking at what you're doing, I mean, you should be getting paid for it. You never see a medical doctor not charge you for something. Why did dentistry do this to themselves?
Well, because of the bundling and unbundling controversies that happened whenever the advent of DSOs came on. You know, a lot of dentists see that as unethical. I remember there was a huge hullabaloo. There was a dentist who was talking about getting paid for an implant, and someone looked at his billing codes that they used, and they were like, "Wow, you're committing fraud." And I think they reported him. Bone retention screws. So we'll get into that in a little bit. So you know exactly where I'm going with that.
Yes, I know.
Things in medical are called what they're called due to the function that they provide, rather than due to the colloquial term for them. So, or the repair that they're making. It's the function within the repair. So, medical codes, ICD-10, I think is the last thing I really looked at. Are they on 11 yet or not?
No, we're still on 10 because we're behind.
I thought so. I thought they were supposed
and
to. And
now Medicare, Medicaid, veterans, which pays wonderful for the veterans. They're higher than you would think, the fees. And all of those are requiring ICD-10s now because we're so far behind. So don't think that dental is not ready, because if you look at your dental forms, there are rooms for ICD-10, and for Medicare Advantage plans and Medicare, if you have Medicare and it doesn't cover the dental, but you have a secondary that will cover the dental, even though it's medical, you still have to get a denial from Medicare. So the simplest way for an office to do that is on the dental claim form to Medicare, regular red and blue card, Medicare. But they have a full secondary from their job yet. They're in it yet. They're still working. They then can bill for the secondary, but they have to have that denial.
Let's get into a couple of things. I want to talk a little bit about the CE that you teach. I want to talk about the fact that you bring the teams in so you can create systems rather than tasks,
right?
Which I think is a very important qualifier about what you do. But I think that it's important because most of the dentists out there have never done an ICD-10. I have. I took your classes pretty early on.
Yeah.
I think you told me last night I was one of your first students.
Yeah, you were one of the first.
So I remember you were shocked because I brought my entire team with me.
Yeah, and that it still shocks me today.
That was expensive.
Yeah, but it still shocks me today because last year at the same meeting that you have attended, a doctor with 7 team members came, and I was impressed. And I went right over to him, and this is a very personalized meeting. We don't leave. The speakers don't go to a room to sit. We stay with the people.
You couldn't get her to be formal if you tried.
No, there's no formality in it.
Bronx coming out, I'm telling you.
Yeah, it is. But you know what? The more information just from a conversation like we're having can spark something in a doctor to say, gee, this could help me. And I can't expect my team to do it if they don't learn it.
Right. And I think one of the big problems, this is what I was kind of getting at earlier, is dentists don't understand the differences in our billing systems.
Yep.
And so I'm going to give a weird example. It's a crazy example, but guys, I'm kidding you not. This is a true example, and I'm going to actually have Christine tell you the entire thing, what it would look like, because I don't know. It's been years since I've done this. But so in dental, our codes tend to be procedure codes. And so medical is different because I like to call medical story codes. Mm-hmm. So does that make sense?
Yeah, so they are.
In the dental field, we might look at a tooth. Let's say tooth number 2 needs a root canal because they have gross coronal decay approximating the pulp. The tooth was tested and it has refractory pain, and it wakes them at night, and there is a 6 millimeter probing depth on the facial with a purulent discharge. We're going to look at that and we're going to say, oh, we've got all this evidence. I know this person needs a root canal. And if I do a root canal on a posterior tooth, it's really standard of care. I should do a crown too, because these teeth can fracture and we're trying to save the tooth. So that's as far as the dentist goes. He puts down a code for a root canal. He puts down a code for a crown. He might make some observations and testament to his diagnostic tools that he used, the evidence that was acquired, his thought process. But that's more than most dentists do. On the other hand, if someone comes in bleeding into an emergency room and they've been at the beach, their code may begin with shark bite, second encounter. Okay? So their codes tell the story of how the injury happened, what things complicate the injury, and what things necessitate the treatment rendered. And then, and only then, will they have the treatment rendered. So I really want you to break down one of the exploded codes. I mean, one of the monsters. Give us a code, if you have one off the top of your head, and explain the story that code tells so that people can kind of wrap their heads around the differences.
Right. And that's such a funny point, because part of the program I teach is I have the team member come up with the patient's chart and tell me the story.
I love it.
Okay.
You didn't do that whenever I took
all right. Well, awesome. I've evolved too.
Right?
So, but he's 100% correct. Diagnostic codes tell the patient's story. But remember, this is how it would go. You're the primary physician the minute that patient walks into your office. Not their medical doctor, you. However, you want to have the patient's medical information, the medication they're on, what is the diagnostic codes the doctor are using, because it's part of her story. So you're going to see a patient, she has severe periodontal infections, and she was referred to you by her medical doctor because she needs a procedure, and he will not do it without that bleeding and pus and bacteria and all the other things that are going on cleaned up. Let's just say cleaned up. So you diagnose her with severe periodontal infection where all 4 quadrants, 2 quadrants, whatever. But then you tell the story of how that patient evolved into having it. So when was the last time she was seen in a private practice, dental practice? Was she seen, did she go to an emergency room, which, believe me, more patients for dental go to an emergency room than you even could believe. And they can't treat them. So they refer them to a doctor or they give them pain medication, which that's not the answer. But she became periodontally infected due to the medications that she's on. She's diabetic, and you need to know, because that is why she needs your surgery.
And the important thing there that's missing from that story is that diabetes is worsened by periodontal disease because there is a positive feedback loop which causes blood sugar to be irregular whenever you have periodontal disease. And so that's your complicating factor that you would use in your ICD-10 code.
Absolutely.
This is why the treatment is needed specifically for this diabetic patient. And that's how you get paid by medical. In dental, we just say, she's got a radiolucency, she's got pain, she's got pus, she needs a root canal.
But see, even if you did scaling it, it's a story even on dental. Today, more denials are in perio than ever before. But if you could just take a look, take 5 seconds to say, add in the updated ADA. I don't say many positive things, but this is a good one. The ADA new medical dental questionnaire. It's better than putting in your own, and I'm going to tell you why, because the first thing a patient asks, Why do I need to give you this information? Our question is to say to them, instead of waiting for them to say that, let them know our doctor is an oral physician. He is. His treatments will involve connecting with your medical provider so that we can get you healthy and keep you that way, not because of what's happening in your oral cavity, but what it's doing because your diabetes is out of control.
And some patients don't want that. And the nice thing is they can self-select themselves to the doctor down the street.
That's right.
Because when you select for patients who actually truly care and think of you as a physician, you become a physician.
That's right. And that's what we need.
Better.
We need to do that. I worked with Dr. Giddin at Harvard, and he passed like last month. And I'm so sad about this, so I want to give him kudos. He was a medical provider. He became a dental provider backwards. Most doctors do the opposite. And he taught at Harvard. And he was really the person that pushed the first year and second year students to work together. And that was his mission. And naming dentists an oral physician was part of it. And it is truly what you are. You could be a DDS or a DMD. Actually, the law says you are a medical provider.
Perhaps an orgnathic physician.
Yeah, well,
but a physician of the face and mastication system.
But they are medical providers. We are medical providers. Think about this patient. She can't keep her diabetes in control, which could kill her. Forgetting about what's going on in her mouth, it could kill her. The pH level moves up and down, up and down, up and down. And every time that happens to a diabetic, they're sick. And it's up to us to tell that patient. Actually, without a medical history and without that conversation, in today's world, you're committing malpractice by not having a medical history and informing. If the patient refuses, that's fine. There's another thing I want you to do. Get an informed refusal. Make sure the patient reads it, says they understand it, sign it, and have a witness sign it. Because I've been to court.
I'm going to disagree with you. Here's why.
Why?
We choose the world we live in. If you have a patient who refuses treatment, but you still see that patient, then you have opened up the book to a lot of troubles.
Yes.
It is often better to simply dismiss the patient before seeing them so that there's no physician-patient relationship with them, because then there is no legal liability. The second they sit in your chair and they open their mouth, or actually the second, if I'm not mistaken, the second someone takes their vitals, you have a doctor-patient relationship. And the second you have a doctor-patient relationship, you are liable for anything that happens. So I just told those patients, I'm not the right dentist for you.
And that's fine. But if they come into your chair and you're diagnosing...
Well, they better not have gotten in your chair unless they filled out my paperwork.
But this is...
Not everyone does things
so what about they fill out your paperwork and they get in the chair? I've seen this happen. And I've testified in a court for a doctor because he did all of that. And the judge will always defer to the patient first. And the question is, did you understand why you needed the treatment? Not that you needed, why you needed the treatment. And she says no. Of course.
A good lawyer would say, Mr. Dentist, do you understand the legal precedent that the judge is discussing? And the dentist would say, no, I don't.
No, well,
is that because you didn't go to law school? So you're saying there's no way that this judge could have given you actual informed consent about this court hearing today? That's what a good lawyer would say.
Yeah, but the lawyer that's working for my dentist, let's say, the doctors I work with, he's already got me talking to them.
Right.
And if they're learning the things that could protect them, and how did I learn that? I didn't learn that in dental. I learned that in medical.
Right, absolutely.
I work for the chief of spine surgery.
Well, and those are great lessons to bring into dental.
Yes, there was no way he would even see a patient without all these forms. That's number one. Without x-rays, because he was treating the spinal cord, and or an informed refusal. Even if they didn't accept surgery that day, like say, yes, I want to do this. He said, you could go home and wait, but this form is necessary because the minute you leave here, at this point, you're no longer my patient.
And going over the patient history, even if it's just been signed, it's one of my big pet peeves. The way that doctors do
gotta
this,
make sure.
It's obnoxious, but you have to do it legally. You have to bring out the same medical form they've already filled out and ask them the same questions again for confirmation, because most people will just check boxes. But here's why. It's not because it's actually important. It's not, because if they're going to lie to you, they're going to lie to you. What's important is that afterwards in your notes, you say reviewed new medical history with patient, confirmed all answers given. That saved my butt whenever I had a patient who smoked, who was having implants done.
Yes.
And she continued to lie about smoking, even though we could smell it on her. And I would note every time, although the patient was asked about smoking, she still claims that she was not smoking. The front desk said she saw her smoking getting out of the car. I smelled smoke on her. However, because our patient has told us that she is not a smoker, we are going to treat her as a non-smoker. And that saved my butt.
That's why observation and everything should be documented.
Absolutely.
So now this program that I'm working on, it's going to have, when you're the doctor and the assistant are in the operatory with that patient, everything you say and do will be recorded
A lot
with
of
AI.
dentists like that.
This is going to save so much time, and it's going to make your lives easier, and it's going to give the documentation you need. Because let's face it, doctors do talk.
So in 2017, I created something called Voice Dental that did exactly the same thing. Doctors didn't want it because they were afraid of the liability of accidentally saying something wrong.
Oh, that's silly.
Yeah. So I want to give you an example. We talked earlier about a shark bite. Right? It was kind of a fanciful thing,
Yeah,
Powers making a joke. So ICD-10 code W56.41XD. That is a shark bite. It may also include the subcodes or back reference annotations of V00Y99, external causes of morbidity if the patient died, or W50-W64, exposure to animated mechanical forces. In other words, you got bitten. Or it could include the code W56, contact with a non-venomous marine animal, or it could include all of these, because if you died from the shark bite, it was because you're exposed to animated mechanical forces of the bite, and the shark was non-venomous. Your codes with ICD-10 can be this freaking big.
Yeah.
And that story can have as many chapters as are necessary to get the patient paid by insurance. And that's powerful because that series of numbers and letters tells a story, a narrative that is never going to get read. Because, folks, if you write a narrative that's a page long, guess who's getting a denial?
You.
If you write a narrative that's one sentence long, guess who's probably going to get a denial? Your perfect narrative, I would say, is about 5 sentences.
The one thing that I would say is when you are doing this conversation with the patient and you're documenting, the biller must match the diagnostic codes to the doctor's documentation.
Right.
And when you first start as an office, as a team, having everybody on the same page helps. So now I broke it up so that it would help the biller, right? So she could actually pre-authorize or pre-verify benefits before the patient comes in, pre-authorize the patient saying I was referred for implants. Well, get a CBCT scan pre-authorized. Or they're coming in because they have severe bleeding. Get a pre-authorization. You don't need to use it if you feel like you don't. But dentists are on, they want to do it today. Doctors send you someplace. We have to remember there's a difference. They send you for a CBCT scan, an MRI, or whatever, blood work someplace else. We can do it right in the office, but we still have to work in advance.
When I was doing sleep apnea, I actually formed a company with some doctors who own a sleep center. And so the way that things would happen is if a patient went into the sleep center and said, hey, I need to be tested, my PCP sent me in for a sleep test, on their questionnaire, they would have a little section that said, do you know that in some cases, a dental appliance may be appropriate treatment for sleep apnea? Click yes. If you are interested in this modality of treatment, check this box and we can refer you after the sleep study. So they would then refer me, that patient, or refer that patient to me. I would do my examination, do their Malin potty and all that kind of stuff. And then I would send my thoughts back to the physicians. Then the physicians had a billing company that they worked with, that because they were physicians in a sleep center, and those billers would write my code for me if we actually did a sleep appliance, and I would pay them a fee for writing the code for me. And if I found a patient who had an AHI of a 42 or 45 or something like that, and I'm like, hey, you really need a CPAP or a BiPAP, I can't make that designation for you. You need to speak to a pulmonologist. I have one I work with. I respect his work. He knows dentistry. I know the sleep side of things. By doing that, we can give you the most options that you can possibly have, and options are power.
Yeah.
Would you like me to get you a referral over there? And then they would get referred over to the sleep center. And so we had this wonderful relationship where I was getting the information from them about billing, and I was being able to bill things out. My first sleep appliance, we made $45,000 on.
I know, I remember.
Oh, I forgot I told you this story.
You sent me that. I know, and you were like on my Hall of Fame.
Right? So this stuff really works, guys. It's not crooked. We as dentists tend to think things like, if you see somebody call and I don't know what the correct modern terminology is, please correct me here. You see someone call an implant a bone retention screw. What do they call it now? What is that?
Technically, the terminology for an implant in medical is reconstruction. And to get an implant covered, you need to tell them how much bone is lost, severe, moderate, whatever. And not only the bone, but, the perio condition of what you're doing, and atrophy.
And contributing health issues.
And all the health stuff. So without that, you're not going to get covered at all.
But the problem is that when dentists see those codes written in English, for instance, exposure to animated mechanical forces being a bite, they look at that and they call bullshit. They're like, this is a scam. This person is trying to scam me. They're going to get me in trouble. And it's because we operate in such a different vocabulary than what medical billing has to operate within.
In my humble opinion, I've seen medical, and I believe that medical will be the providers. Dental is lowering their fees again this year. So let's put the cards on the table. Last year was not a healthy year for anybody financially. And you have to look at dental insurance or an in-house membership plan. An in-house membership plan will help you more than being in network with a dental insurance. I'm going to get killed for this, but it's true. And I'm not saying go drop all your plans. That's not what I'm advocating. I'm not advocating
We
it.
may differ on that. But if you do it responsibly. And if you want to know how, reach out to me and I'll help you.
Yeah. I mean, that's what I'm saying. There is a way. Like one of the first things I would teach in the office is when you have to write off something because you're in network, write it off towards the plan, not write off. Because then every day, the doctor could look at the day sheet and say, okay, I produced $2,000 under Insurance X, and I only collected $800, and I wrote off the rest.
Right.
Like, why am I doing that? See, and that is informed decision making, not just spur of the moment.
Well, what most dentists do is first of all, your production is not important, people. Your gross production doesn't mean anything. Your net, or the money that makes it into your bank account, is the only damn thing that matters. What most dentists look at, because they have a fundamental misunderstanding of the words busy and productive. You can be very busy if you're in network with Delta Dental. Delta, don't sue me. Well, please. And you can be very busy, but you won't be very productive. You won't be profitable. What dentists look at is the number of patients on a plan.
Yeah, you can't do
versus the amount of money they're losing by having that patient in the chair. So if you guys are interested, I actually posted it on TBOD. I created a spreadsheet that shows you the value of your chairs based upon what insurance patient is sitting in them. What you do is it has a standardized procedure code. Let's say it's a crown, and it says, okay, here are my UCR fees. Here are my actual reimbursements from the dental insurance, and you put all that into a table, and you guys can make this yourself. That's why I'm going into the long-winded explanation. Then you can look at what the value of your chairs are as a UCR patient versus a Delta patient versus United patient versus, Cigna or what have you. What you'll find is, in general, you can lose 50% of your patients. You can see half the number of patients that you saw if they were entirely dental insurance driven and make almost 125% more money for half the patients. So when you start looking at things like this and you say, well, if I have a Delta patient in my chair, I'm actually only making 40% as much. If I have a United Healthcare patient, I'm only making this much. Then you look at that and you say, if half of the patients I'm losing, if all of my patients left, all of them, how many patients would I have to see at full fee service to make up for that loss? And the numbers will surprise you. You are horrendously underpaid. And to be frank, if that is not your finding whenever you run these numbers, it generally means your UCR is too low.
Yeah, and that is another issue. But when you're in network, it doesn't matter what your UCR is. So
That's for non-covered services.
Right, baby. And when they're learning medical, you can't have two fee schedule. So the thing to add on to how you look at a chair and what it's worth, years ago when they had capitation plans, that's what they taught. Okay, this is how much your chair time is worth.
Right.
We never made that worth. Never. You're not going to. It's not going to happen unless they never come in. If a capitation patient doesn't come in, then you're making money.
Well, that's the trick, right? Because
Isn't that the trick?
The old trick used to be for capitation plan. For those of you who don't understand capitation plans, basically you become the dental home of a patient, and the insurance company will pay you $30 for that patient per month. Okay, well, if that patient doesn't have any needs, you have 100% profit off of $30. But if that patient comes in and they need a crown and you're not allowed to charge for that crown, you only get that $30. Well, that's $360 a year. It's going to take you, 6 years to make up the profit for that crown. But you have to think this way, guys, because if you don't start thinking this way, it's getting harder and harder to stay in business.
Yep. And that's why with medical, I advise doctors not to go in network unless they are seeing a profit already by doing it, and then make relationships like Paul and I made relationships with the hospital right across the street from our practice. We moved to that location on purpose. They had a sleep lab. He was able to go right there. We stayed with the medical doctors that we were working with. We did not do the sleep test. I still don't understand why dentists are buying the sleep test and thinking they can make money on it, because you can't.
Well, that's what we were taught to begin with. You remember I actually bought, I can't remember which one, that cool arm one. Looked like a Super NES.
Yeah, but only the doctor that reads the test can get paid for it. So you're buying something that you can't make an income on.
We actually charged that a D99 office visit.
Well, you couldn't now.
Really? You got to be kidding me. Because it was a non-covered service, so we charged an office visit to dental. So we got paid, I think, $150.
Yeah, well, dental now added some sleep codes, which is ridiculous because they're not covering it.
Because they don't pay them.
Yeah, so it's just a ridiculous thing to buy new books.
When dental adds codes for things that they don't pay, it is simply so that they can artificially bracket prices. Because what they're trying to do is they're trying to change everyone's UCR, because they know that most of you guys set your UCR not based upon the cost in labor and materials that it takes to provide the service, but rather based upon what everyone else in your area is paying. Mm-hmm. So if everyone in your area is seeing reimbursements at a certain level and they reduce their UCR to that level, which, guys, that's so wrong-headed, then the UCR overall will be reduced, and the dental plans will pay on their table of benefits a percentage of that with your major and your minor and everything. Mm-hmm. Okay, you guys know how this works. Whenever everyone goes down on their UCR in an area, reimbursements in the area decrease.
Well, they're decreasing across the state.
Oh, they're decreasing across the nation right now.
And the whole nation is going to take a hit. Because I go every year to a very big meeting, and they're not giving in, but they're not paying either. So what I learned in the medical, and what I love about billing medical, is that if you could prove medical necessity by the story that you're telling, that patient is going to get the payment. Now, Medicare was doing so bad, and I find this miraculous with having any dentist participate, and they did add more treatment to the policy this year. Not enough, in my humble opinion, but they did. They made a non-participating provider contract. And what that means is you charge your fee, the patient gets reimbursed. You just bill your fee, the patient gets reimbursed for whatever Medicare covers. So that gives you...
Are you still...
You're not a network that way.
But are you still under the auspices of the contract such that the government can come and seize your records and investigate?
Anybody could come seize your records today. Any insurance company.
Well, if you're in network with them.
No, not only if you're in network.
If you're in network, you've signed a piece of paper that says you'll give it to them.
But you're not in network with the non-participating. Right. You're saying, I'll see a Medicare patient, but I'm not dealing with the bill. I'll bill it for the patient to get reimbursed. Because even medical providers no longer want to be in network.
Well, of course not.
So
I want to talk to you more about that afterwards, because that's something that's happened since I've retired, and I want to know more about it so I can give people good advice. But when you began teaching this type of stuff to dentists? Because I'm trying to bring us back on track. Because you and I just like talking, and we've gotten far off track here. All relevant and important information, guys. But when you began teaching this kind of CE to dentists, what is the first uncomfortable realization that most of them have? What have you heard from them?
It's not from them. It's from their team. This is too hard. Mm-hmm. And that's because they're not even trained in dental. Of course it's going to be too hard. Now you're adding another set of codes, and you're cross-coding, basically. But I try to tell them from the very beginning, patience is a virtue. I am married to a dentist, so it's important for me to give whatever I can to any client that comes my way, because I know that doctors pay a lot of money to consultants. Our meeting, that 2 days, they have the opportunity for a month to send me a claim, to look at it, to do a Zoom with them and teach them what needs to be changed, what doesn't need to be changed. And I find that engagement so beneficial for them. So I've continued it and made even a membership plan for it, for that reason. If not, we opened a medical billing company so that with no contract, we do not have a 1-year contract, a 2-year contract. It's basically a teaching program. So while we're doing it, you are getting paid and learning. When you feel confident enough to do those big cases, take it away. There's no, you're contracted with us. I've had too many clients come to me with these contracts that they can't even get out of. And they're paying this monthly fee for no reason. Once you learn, I'm telling you, it's just like any other billing. And if you're doing the same thing over and over and over again, the difference with sleep apnea and everything else in medical is it is dependent on the patient's health history. That's the big learning curve. But other than that, the treatments, once you learn implant coding or bone grafting coding, there's a few rules in there. You have to know, are you buying bone grafts? Are you using plasma? What are you doing? And the big thing that you learn when you're billing medical, you raise your fees because you're going to get paid more. Mm-hmm. So you get paid about $800 a quad for bone grafting. That's about the average. But if you're purchasing bone, you add that to your claim form because they look at you produced $800, but you spent $300. So now, and this is something dentistry never did. So now we're going to look at your production at a higher level because you laid out the purchase for the material for the patient. So if you're only charging $800, your profit margin's lower. Mm-hmm. It teaches us to think bigger, not smaller. It's and to know your true worth. What are you really going to make on this patient?
One of the things that I saw a lot, I was pretty deep into implants, as you know, doing a lot of big cases. And one of the things that I saw as an emerging trend back in 2018, 2019, I don't know if it's taken off or not. As I said, I've retired since then, is people buying bone mills and demineralization matrices where you'd add chemicals and they would dissolve the neuronal tissue and the vascular system within the tooth, and it would grind it up and it would turn it into basic calcium phosphate, hydroxyapatite, guys. Everything, bone and teeth are all made of it. And so what they would be able to do is whenever they were doing this, they'd buy it specifically because they'd gotten into medical billing, because there is a code for harvesting of the material to begin with. and then another code for placement of the materials.
Yes.
And so they would really be double dipping on that. The machine, I think it would cost you, $30 or $40 per bone graft. And people saw that and were like, well, I can, at the time, Maxius was like $45 a bottle or something like that. And they'd say, oh, well, I could get this bone from this company and it's only $45 and $45 and I don't have to buy a machine, this and that and the other. What's the point? Well, the point is that the actual action of gathering the biological material was a service that you could charge for. There's also a dental code, by the way, guys, if you don't know, for actually acquiring biological material. We used to use it for PRF, for blood draws. And then we charge the PRF out separately because it's application of a biological material.
I recently had bone grafting done on my sinus lift. And it was my bone, but with blood. So that's technically a plasma.
Did they use a PRP or a PRF? Did they make little membranes out of it, or was it just liquid?
No, they made membranes out of it. Okay, so that was a PRF. So that is coded differently, and you're not really spending. It's your time, but you're not really spending anything because the patient's bone and the patient's blood, and it actually is, in my humble opinion, better.
Oh, it's absolutely better.
Because it's the patient's. And I've seen them take bone from patients.
Iliac crest.
Yeah.
What have you.
And, it is remarkable that is regenerating your own bone.
Absolutely. But that was the whole philosophy behind
so it's a little different
tooth mill
today. But they do it. Absolutely. A lot of surgeons do it,
Previously, what would happen is they would excise like the iliac crest of your pelvis. Mm-hmm. Then they would take that and they would use that as a block graft. But that requires an entire surgical team. And
you're in an operating room.
I thought it was kind of a brilliant move with these companies that made these tooth mills where you could actually, you harvest something that you as a dentist are used to doing. You extract the tooth you're going to replace. You decontaminate it, you remove all the other biologicals that are not mineralized matrix, and you've created an autogenous bone graft, which is, we all know, is the best bone graft you can use on a patient without the undue necessary, second surgery.
Right. It is worth it on a second surgery if the patient has been edentulous for years and it's really bad, and that, is a way. Cancer patients, Absolutely. I've seen a lot of that redone now. So there's a lot of different, let's face it, we're in technology world at this point, and it only gets better. The services may be the same, but the treatment alternatives are better and better and better for many patients.
Yeah, absolutely.
And so, yeah.
So why do you think, so when I look at this as a concept with billing, I think of, fair trade. It is the trading of one person's labor for the trading of another person's labor through the intermediate of money. Mm-hmm. Why is it that you think, or why is it that in dentistry, you may not think this, but I think in dentistry that billing is one of the most critical but least respected portions of the systems within the place of our practice.
Yeah, and I don't understand why, because we're putting a person in charge of our entire income, the ROI of that office. And I'll never forget when I was working for somebody, a different dentist, and he would come up the last day of the month and say, we're short. Like, you don't worry about it on the last day. You have to worry about it on the first day. Why aren't there goals? Why aren't we making this money? Irregardless of whether you're billing or not. So, these are, a company like McDonald's doesn't let a McDonald's clerk close the drawer and leave. Mm-hmm. We don't even do that right. So there are a lot of issues with the amount of training that a front team is doing for us without education. Now, the office managers, they're getting more education. I'm not saying they're not, because they are.
With ADOM and things like
Well,
that.
ADOM is now sold. It's gone. I was a founding member. It's over, done. It's sold to Shine. Billing companies are opening up everywhere, but I like the independent people better than a company because they are not as diligent as those single owners. I can't tell you how many billers I know in today's world, whether it's dental, medical, or a combination of both, that are excellent. Better than any company could give you. One-on-one care, no matter what you need, no matter when you need it, and not binding you to them. And that's what I appreciate. But I find that the office managers are still doing a lot of the work in the office and not having a team because we're shorthanded. And that's a problem. So this year at the meeting, I'm having a virtual assistant company group talk about having a virtual assistant. I've seen it work where the phones are not answered by the office team. That frees them up so much. They take all the new patient, they get the information, they do the verification, they do the billing information is ready. If you need pre-authorization, they're the ones doing it. That eliminates the office answering the phones as they're checking out somebody or if they're having a conversation with somebody on a treatment plan and then being interrupted. It's not okay. That is your bread and butter, that patient, and she is to be respected, not only for the case, but as a person. Because I want to be respected when I go to a doctor and I need to ask questions.
It's crazy. When you treat patients like people,
Yeah,
your case acceptance goes up.
absolutely. They're not a number. They could go to anybody else. That's free choice, and we still have it. Have the patient understand everything before you leave them. And if you have to do a Zoom call afterwards, ask permission. Say, I know this is a lot to take in. If you'd like to set up a call with your significant other, we'd be happy to do that for you so we could go over it again. I have found those little things sell more cases and give patients the ability to want to be in your practice, who refer people to your practice. Not only because you're great at what you do, but because your team is great at what they do.
Mm-hmm.
That makes a big difference.
So what separates practices that are doing medical billing that stay out of trouble from those that don't?
They're diagnosing more and documenting it. I could tell you, I've been to thousands of practices where they're not documenting what you said before. Why do you need an x-ray? What is that for? What did you see in the x-ray? It's never documented. That is like a big malpractice issue right there.
And not just for medical, for dental as well.
Well, I'm talking about dental.
Yeah.
Medical does document. They are referring out, whether it's a mammogram, whether it's an x-ray, but then they document the results written by somebody. I also tell dentists, whether you're billing, dental, medical, doesn't matter. If you have a CBCT scan and you're not reading the whole head and neck, you're committing a problem for yourself because it has to be documented. And that includes the cervical spine, everything. So we're not
depending on your FOV, yes.
Yes. So, but you can't bill a 70486 if you're not reading it.
Yep. So you
I find that dentists have the biggest problem is that documentation piece where doctors have it down, and we are giving you many ways of doing it, but, that's besides the point. The issue is that when they see how they get more respect from a patient. Mm-hmm. They get the ability to help a patient. Now, this doesn't stop you from billing dental also. Mm-hmm. You can bill multiple plans. I have patients that have 2 insurances each, husband and wife. We've billed all 4. The rule of thumb is never collect more than your fee. Mm-hmm. The minute you collect $1 more than your fee, you have to send that $1 back.
Right.
That is another error in the making, and I hate to keep talking, but if you have a negative balance on an account, you better audit that account. Because if that money belongs to any insurance company, it could be dental, it could be medical, and you didn't send it back, that is a lawsuit waiting to happen.
You have 1 year.
Yeah.
If you, and that's not just, guys, it's not just overcharging.
It's not an overcharge. They got paid more than they billed out.
Well,
or they thought they were getting.
Well, let's be specific, though. So where it actually often happens is, let's say I have a patient who comes in, and the patient has multiple needs, and I do a package treatment. So, for instance, I say, well, we have to do bone graft. There's a price for bone graft. Oh, they can't even see that on camera. Oh, well, you got to do bone graft. Okay, here's your bone graft, guys. You're getting paid for your bone graft. Well, we got an implant we got to put in. Okay, here's your implant. We're going to put a crown on that implant. And in a very loose sense, this is your treatment. Okay, so when you tell the patient, hey, look, I'll give you $100 off if you go ahead and pay for everything up front. Okay, well, 6 months after our graft, we're going to go ahead and we're going to put on our crown. Patient takes a vacation. You get out to 12 months, and they haven't received their crown yet. This technically has to be sent back to the patient, and that's it. It's all they wrote. It has to be sent back to the patient legally. So, finish your treatments within a year if you're going to be actually charging up front for the entire treatment and doing a package or a bundle, which I do very much recommend. Bundling makes everyone's life easier, but be aware of the legalities.
And that is the most important thing that office managers and the entire team, including the doctor, needs to learn. There are dental laws, there are lawsuit laws, malpractice laws, a whole gamut of things that we have to take into consideration the minute we see a patient. I mean, they can complain about anything, but you have to remember the patient is looked at by the judge as innocent until proven guilty, like any other lawsuit. And if the doctor did not have this documented or did not have the form signed, the consent forms or whatever, or send that crown to the patient, there are issues that they could just get right under the table with. And lawyers know them all.
So something I've seen a couple of times in practice and actually occurred with me at one point. How often is it not because the documentation is absent, but rather because the documentation contradicts itself?
Oh, that's a big point.
So talk to us a little bit about that in the broad scheme of things.
That's why SOAP notes are so much better, because you document what you need and nothing else, okay? You really... I developed a form with questions, and I want those questions answered, because no biller, whether it's a company or whether it's the in-house person, can bill unless the doctor documented it correctly. if he said, we offered implants, the patient didn't want it, but we're going to do the bone grafting and she's going to think about the implant. That's like too much information. If the patient's going to do the bone grafts, then document the bone grafts. Your treatment plan should never be deleted.
Right. Okay. So that is definitely an important point that a lot of you guys don't know. Every PMS actually has an option for you to put the full treatment plan in. Treatment plan refused by a patient. Click a button.
Yep.
It will no longer show up in your ledger, so it doesn't show up as an outstanding balance. But it does show up on the record search.
Yes.
And when the patient says, I was never offered this treatment, if you have removed that treatment plan,
you're done.
You are finished.
Yep. So that treatment plan shows the whole picture, but we didn't actually do the whole treatment plan. Mm-hmm. So in your documentation, you can simply write, patient wanted the bone grafting done, the treatment plan is left. There's a treatment plan left. And go on with what they did accept and how you diagnose, what did you do, blah, blah, blah. And there are more diagnostic things that we should be doing that we're not doing. Mm-hmm. I'm a big believer in the oral DNA. Mm-hmm. Why? I can't tell you how much information that gives to you to help a patient get medical coverage.
Let's talk a little bit about a couple of different types of tests. In dentistry, we tend to think of our test as definitive rather than exploratory. And let me put a real fine point on that. So there are photoillumination or fluoroscopy, I should say, tests that you can do on the oral cavity, and they'll show ATP utilization. ATP utilization is highly associated with karyogenic bacteria. It gives you a solid number. So that is a screening test. Mm-hmm. And an X-ray is a definitive test. So you take an X-ray, it shows you an image of the tooth. If you do this fluoroscopy, it shows you an indicator that there may be karyogenic bacteria, right? Which indicates further testing. And that's not an exact perfect example, but one is to say, I have the answer. The other is to say, I need to look further into other possibilities. Talk to us a little bit about that, because it's something I think dentists don't think about. They think more on the lines of, I did a pulp test, the patient had refractory pain, they have an irreversible pulpitis, the treatment for that is a root canal or an extraction.
And there are many times that we have to do something else. The problem I'm having is that we're not doing enough diagnostics. That's what I'm seeing. You know, if you're going to go ahead and do diagnostics, they made a simple finger prick blood test for in-off dental offices, because if a patient comes in for a prophy, let's say, and they have red puffy bleeding gums, and they didn't give you a medical history, and the hygienist then could say, or the doctor can say, you have indications. You're not diagnosing. You have indications that we are concerned about. That's that finger prick test. We're not diagnosing the results, but we're going to refer them to a endocrinologist.
All right, let me explain that, guys. So what she's saying, because we're both diabetic and she's talking to me, is whenever you go into a dental office, you go into a physician's office and they do a finger prick and they're looking at your blood sugar levels. It says that right now your blood sugar is high. Mm-hmm. Right now your blood sugar is low. So you've got hyperglycemia or hypoglycemia. It doesn't say your blood sugar is always high. It doesn't account for, I just drank a glass of orange juice. Mm-hmm. What it says is this indicator says we need to do further studies. We need to do a fasting test. Right. So we know what your blood sugar at resting is without any kind of interference. it says we need to look at your A1C. What has it been for the last 3 months? Is this a historical trend? Is this new? And that's exactly the point I was trying to get to, is most of the tests that we do in dentistry, we tend to think of as definitive tests, whereas these other tests that we're talking about are more exploratory. And that's much more in the lines of medical practice than it is in traditional dental practice. Traditional dental practice, and let's face it, guys, it started off as you go to the barber shop and say, hey, I got a toothache. And he's like, hey, I'll rip that thing out of your jaw while you're here. Would you like me to take a little off the top too? We are becoming physicians.
Yes.
But we're not there yet. And I think that it's very important for our future that we do. It's not about a loss of autonomy. It's about things being repeatable. It's about systemization. It's about scientific data that can be pulled when systemization is used so that we can find trend lines. It's not about robbing you of your autonomy as a doctor, because what you decide to do for a patient who has diabetes, they may put you on metformin. They say, hey, let's try this. They may say, hey, let's change your diet and your exercise. They may say, hey, look, I'm going to put you on Ozempic, or I'm going to put you on, long-acting or short-acting insulin, or what have you. It does not rob you of your autonomy as a doctor. All it does is give you a really well-fleshed out diagnostic tree so that you can look at the options, present them to the patient, and say, look, this is what I think is best.
Yes, absolutely. And the collaboration of medicine. Medicine's been collaborating forever. You don't do a surgery without an anesthesiologist in the operating room. You don't diagnose a patient without lab tests. They're collaborating. And if you have a special need, like your regular physician may refer you to a cardiologist or somebody else, okay? So it's not abnormal in medicine to collaborate, and they're learning why they need to collaborate with us. And if we don't catch up to them, we're not going to even understand why they're sending us a patient.
There's I'm a huge nerd. I mean, you've seen my place. We aren't supposed to say yes. You're supposed to say, no, you're not a nerd. So anyway.
No, you are a nerd. That's why I like you.
This is true.
One nerd to another.
I'm reminded of an old Star Trek episode way back in the day. It's 1970s. And it said, it had this entity that they encountered. And it said, hello, hollow tubes with bags of mostly water. So we are really a tube. We've got an opening at both ends, and we're just a bag of mostly water. And the dentist is treating only one hole in that tube. And I don't understand. I mean, I do intellectually. I know what the history is, but I don't understand how people can't see that that tube is connected by two holes.
Patients are understanding it faster than the dentists, which I think is very sad. But they are learning it. It's in magazines. It's on TV. Your doctors are learning it. They're looking for oral lesions. They went as far as making a medical code for varnish. Why do you think they did that?
Medical code for varnish. I know where I would use it. I would use it for patients who have some sort of incapacitation that they can't do mechanical cleansing. I would do it for patients who have some sort of emetic response where they're having a lot of vomiting, or as some other corollary or adjunctive treatment to.
But they wanted to know why we were not doing it. And because dental insurance didn't cover it for adults. So they went ahead and solved an issue. They have hospitals now doing oral care if you're in an ICU room because the patient can't. They have nurse hygienists now at hospitals.
Really? That's interesting.
And there's more and more.
The hygienists are going.
No, I mean, they're being trained specifically for patients that are in ICU that cannot do it for themselves. What are we waiting for? For them they can take over the whole field if we let them.
This is a conversation you and I had years ago about me believing that dentistry would ultimately become a subspecialty of medicine, and I still believe that it will. I think it's absolutely.
It's already there.
It's going to happen. It hasn't been recognized by either side yet, but the one fear I have is traditionally what we do is we silo, which means that each one of us knows a great deal about our own specialty. You know the old joke, BS is bullshit, MS is more shit, and PhD is piled higher and deeper. So we silo ourselves within our area of study, and that becomes a great concern when you have MDs who don't know a damn thing about the biological systems they're treating. I recall there was a patient who came in, and she was a Medicaid patient. And her physician sent her with a letter that told me she was requiring me to not use epinephrine with anesthesia. Unasked for. I didn't ask for a consult. And that's not a consult to begin with. That's an order. So I called her and I said, I have a bit of concern here with your recommendation, which I think, judiciously called it a recommendation. And my concern is that this patient needs an extraction. And the doctor said, under no circumstances will you use epinephrine. And I said, you're going to hold your horses a little bit, and we're going to have a discussion. She got very pissy with me. I said, okay, what do you know about oxytocin and progesterone levels as regards pain mediators? What do you know about leukotrienes and prostaglandins and the way that they affect the expression of those two hormones? I don't see where that has anything to do with it. So, well, my understanding is that you're very worried that the vasoconstriction caused by the epinephrine, which, by the way, we use 1 to 200,000 in pregnant patients, not 1 to 1,000, which is what I know you are familiar with. And she said, oh, well yeah, that we use 1 to 1,000. I said, well, 1 to 200,000 is 200 times less than that. And it's not going to cause any issues with vasoconstriction, and it's not going to cause premature birth, which is one of the issues you're worried about. But unmitigated pain, as you should know as an OBGYN, will cause premature birth. So I am calling you as a courtesy to allow you to amend your recommendation. Mm-hmm. Here is what we will be doing. And she faxed me over an amended recommendation. She had never thought about the pain cascade and the effects on oxytocin and progesterone, and she was an OBGYN. Now, you can make the point of saying that this woman worked for Medicaid and maybe wasn't the best doctor. I would definitely support that because she didn't sound like she was terribly knowledgeable. But when we silo ourselves to such an extent that we forget our basic training and the basic biology by which we are constrained, I think there is a great danger in that.
There is a danger in that, and I think that's why collaboration is the best mode of treatment for any patient, for any part of your body, any part. So the fact that they're putting it in hospitals because they understand that the bacteria build up in the oral cavity. Let's face it, we all know you could get a scaling, root planing, and a prophy, walk out of the operatory, and it's already coming back. Mm-hmm. Right?
5 seconds for a pellicle to regrow.
That's right. So why are we waiting? That's another thing I don't understand. Why is dentistry restricting you from doing the whole mouth when the clean side's going to get reinfected as bad as it was?
I know. I had a wonderful professor in dental school, Dr. Steve Lehman. If you are listening to this podcast, I'm talking about you, sir. And he has, I always joked with him, he reminds me of the Here's Your Sign guy. Because his voice is a little bit like that. And he looked at me one day and says, so tell me, do you think the bacteria don't jump across to the other side of the mouth?
That's true.
You know, he makes a good case that if you have that type of an issue and it's not really a single tooth issue that's caused by some other exogenous thing, you know, a popcorn kernel caught in the caught within the sulcus or what have you. It's just a nasty shit soup in your mouth with the bacteria going back and forth and all over the place. So it doesn't make any sense that we're limiting periodontal treatments to a quadrant.
Right.
Yeah.
So I was at a meeting and I sat next to a representative of an insurance company. She was very nice. And I asked her this question. She goes, well, since now they have added in good faith extra cleanings for people with an oral systemic infection, which kills me that many doctors don't know about this. So please look into it because that's 4 visits for a patient versus 2 a year. And the reason is because of the bacteria and the buildup and the infection they have, like a diabetic or a pregnant woman, as we just spoke about. And they can get a full mouth cleaning if we document that they have that, and we don't want to do half of the oral cavity and then 2 weeks later do the other half and have to re-go back anyway.
Right. Well, I think a lot of dentists maybe don't really know the biology of the way that the plaque accumulates or the cross-linking between fusiform bacteria and enterocoli and everything else. Yes, you have E. coli in your mouth.
Yeah.
And everything else that is in the oral cavity. I think they don't understand how that chemically happens and how those cross-links actually allow the calcium and the phosphate in your saliva to begin hardening within this, within this ecosystem of bacteria. Just because the bacteria has not yet caused pocketing and, well, generally you have bleeding before you've got pocketing.
Yeah.
That's a disease state right there. But just because you don't currently have pocketing doesn't mean you don't have biofilm that is not currently in the process of hardening into calculus.
Right.
So I think a lot of people would make the argument that's what perio maintenance is for. But I know a lot of offices, when they do a scaling and root planing, they only do the scaling on that quadrant or those 2 quadrants at the time, particularly the 2 quadrants, so they can avoid being denied payment by the insurance companies. And they don't think of doing an adjunctive prophylaxis at the same time. But in my office, that was part of what we did, is if we weren't scaling that side subgingivally, because we always scaled supergingivally, we were going to be polishing and scaling supergingivally the entire mouth. You're just not getting paid as a scaling and root planing for that. But honestly, unless they write that into the descriptor of the code, I really think there should be an adjunctive code that says cleaning the rest of the mouth of an infected person, Well,
but I'm saying at this point in time, you can document in your notes that the patient is diagnosed with whatever systemic, it could be Parkinson, diabetes, pregnancy.
It doesn't have to be systemic disease either.
No.
It can be habits.
Yeah, well, I know for sure systemic, so I don't want to say something that I'm not 100% on. You must document it, and then when you're pre-authorizing anyway. So pre-authorize it as doing all 4 quadrants.
Don't do that for dentistry. Only medical.
Yeah.
It is a waste of time.
It's a waste of time even on medical.
In dental.
It really is, but it's required.
Right.
So, but the patient's health history will actually help you do the treatment you want. So if anybody asks me what's the most important change, it's the health history. And you can't accept a form with a circle here and draw a line down. Those days are over. It's going to hurt you in the end. It's hurting the patient in the end. They have to answer it. And that's one of the reasons why in today, you could make them fill out the forms online. Mm-hmm. And then if you see it, you could say to them, we can't accept this. I live in Florida now. You cannot go to a doctor unless all the paperwork's there. They will not even give you an appointment at all unless you fill out that paperwork. They have it, they've reviewed it, and then they call you to make an appointment. And I found that to be interesting because it does help you, the patient. Why is the doctor doing that? So he could know who you are before you even walk in the door.
So one of the things I think that we really need to look at when you're looking at your histories, right? And just to make your point here that the history is so very important.
Yep.
One of the things that most dentists don't realize, fully 60 to 80% of your patients are eligible for a D0180. Did you guys know that?
And that changed this year. And added in anyone with systemic infections.
Any systemic infection.
Any systemic infection has to have a DL180.
Okay, so let's talk to them about the things that qualify a patient for that, because I think that it's one of the most poorly taught things in dental school. Guys, I'm a geek. I read the laws and I read my contracts. I know most of you guys have way better things to do than that, but I'm a boring kind of guy. So when I was practicing, a lot of my patients got periodontal exams that you wouldn't think otherwise would. But you are absolutely 100% legally correct to charge one out for a new patient exam if a patient comes in and they have diabetes. They're pre-diabetic. They are a smoker. They are taking a medication that causes xerostomia. Mm-hmm. They have ever had radiation treatment, period. So many of these things, I would go so far as to say I'd be pretty comfortable if I had a patient who came in who had any kind of manual dexterity issue whatsoever, mm-hmm. that I would try to charge a periodontal exam.
Absolutely, you're entitled to it because you do have to spend that time. And, you know, the one thing about medical is the office visits pay by the amount of time you spend with that patient. You have to have documentation, mm-hmm. And I give it to my doctor, like if you do this, this, and this, charge for this. And it works better. It's not the code that's the difference. Right. It's the time you spend with that patient.
Well, one of the things that I think is a huge area where we can use some, definitely we could use some retraining. Mm-hmm. So it used to be back, whenever I first started practicing back in 2012, it was a distinct difference between a regular comprehensive exam and a periodontal exam. Mm-hmm. And that distinct difference was that the verbiage in the CDT code said that a D0180, you must complete a periodontal chart.
Yep.
So complete is a very important word. So it also said on state law that the patients had to be probed at least annually. So here is the problem. Most dentists don't do attachment loss. Most dentists don't do mucogingival junction. And you guys need to be, because that is the difference between completing a periodontal exam and just doing probing. And you cannot diagnose on probing depths. That is not how diagnosis is done. Diagnosis is done based upon bone levels, clinical attachment loss, and bleeding on probing. You need to learn how to diagnose correctly. It is an area I see so many dentists so weak in, and they wonder constantly, Oh, why did Cigna deny my SRP? Well, did you include a perio chart? Well, of course we did. Let me see your perio chart. Why isn't there bleeding on probing marked? Why isn't there clinical attachment loss marked? Why isn't there mucogingival junction? Why isn't there CEJ? None of this stuff is filled in. And if you got CEJ missing, but you have a clinical attachment loss, guess what? We know you made it up. You know?
I've seen it made up quite a lot.
Right.
One of the things I recommend for every dentist is to get Florida Probe. This is the reason that you can put what you want in that system so the hygienist is not even speaking. She tells them, when it says bleeding, this is what it means. When it says bone loss, this is what it means. So the patient is hearing this, number one, educating them, and seeing it on the TV screen, which is a beautiful thing.
Right.
And then after they're done, everything is in that chart. Everything. What you said, what the patient said, everything. So now you have amazing documentation in color. Send one home to the patient and one to the insurance company, and you will not get denied. And when you're doing perio maintenance on the claim form now, the dental claim form, there is a box all the way on the bottom, and it says date of last SRP. Nobody learns these things because the computers automatically update the forms.
Does Delta still have a once per lifetime limit on SRP?
I don't think so. I don't think so.
We hit that with one of the Deltas. I don't remember which one it was.
Well, they're all different too. But that SRP date, if that was 2 years ago and they haven't gone again, why are you doing an SRP without a complete exam? How do you know it's a perio maintenance? See, this is what they're following medical laws by now because of this, and you're not getting paid because you're not following them.
I'm going to tell you what I think the most dangerous phrase in dentistry is.
Go ahead.
And I want you to give me your thoughts and your reaction to that.
Okay.
This is how we've always done it.
Oh, yeah. Yeah, that's dangerous. It's dangerous. That's because there is no training, ongoing training.
Change year to year.
Everything changes. That my hair color changes on a daily basis because I'm older. I mean, everything changes. So without a strong educational system for you and your team, you're missing out on laws, understanding them and how they affect you. You're missing out on updated coding. You're missing out on documentation and the ease. Listen, there's so many pieces of equipment that could help all of this. But if you don't know it, the equipment doesn't matter. Like, I'll go in an office, they have an oral cancer scanner. They're not billing it. Well, because dental doesn't cover it, which that in itself bothers me. But guess what? It's the same light as a medical doctor uses, and it's chemoluminescent light. It's a medical code. And now, if you have a CBCT scan, you can actually bill for oral cancer screening on a CBCT scan. Not every week. You know, you have to look at the age and how many times they want you to do oral cancer screening. But
once for 10 years, and once every 10 years for a 19-year-old, once every 5-year-old.
Well, they've even changed that a little bit because they know now cancer doesn't really have an age. Of course, you get a higher risk as you get older for a lot of things, but there's no range. And oral cancer is a horrible, horrible disease.
Well, one of the problems that we have.
But why isn't dental covering that? Doesn't anybody ask that question? Like, why Did we accept that?
Why is it required by law that you, the dentist, is going to do a head and neck and intraoral cancer screen, but it is not required by law that you get paid for it?
Because the dental insurance doesn't follow those laws. That's why medical covers it.
Mm-hmm.
You see? So they exempt a lot of things from their contracts. And that's like the fluoride varnish. Dental doesn't cover over a certain age. So now medical said, well, what about adults? Older adults get a lot of sensitivity issues and da-da-da. And so they're applying it. So we're having medical doctors apply varnish.
I don't know this for a fact, but my intuition tells me it probably went something like this. The early studies that were done, when they first began writing these codes, were done on your normal adult population. And they said, normal adult population, these people have cavities. When did the development of cavities start in this person's life? And when is it most likely that a person begins to get damage that results ultimately in cavitation of the tooth? Oh, well, that's when they're kids. Okay, so kids, what should we call a kid? Well, let's say anything 18 or younger. I mean, that's the legal age right now. Okay, so 18 and younger. Well, we should probably cover fluoride for those people because we know they're most at risk at developing cavities when they're adults. But what we forget is that I think it's like 30% of America is on 4 medications or more.
Mm-hmm.
And polypharmia, when you're on 4 medications or more, there's a 25% chance that you have an interaction between those medications. And one of those interactions or one of the biological side effects is xerostomia. Any number of other things, including muscular contractions that might result in bruxism, which might damage teeth, yada, yada, yada. Americans are living longer. And so that data, I think, probably just never entered into the presentation when it came to, hey, when is this appropriate? Because you look at things like Cologuard. So Cologuard has a 60% false positive rate.
Mm-hmm.
I'm of a certain age, so I know these things. So Cologuard is required that you do it every 3 years. And the reason is because if you have 3 years of negative results, that means that there's a cumulative data set between those 3. I was actually talking to my proctologist the other day. Won't go into that. But I was talking to him the other day about why they do that. And he said, well, because when we've got these 3 tests, we know it has a 60% false positive rate, so it's highly specific. So we're using that. And we're saying if you didn't get a false positive, that means you didn't get a true positive 40% of the time, every 3 years. Well, that's really, that's pretty close to like a 90%, you don't have cancer. Well, an actual colonoscopy you have to do every 10 years.
Mm-hmm.
And so I think that there is a lot of merit to having those guidelines in place.
Mm-hmm.
Like, let's say, you can only do a cancer screening on a 16-year-old, or you should do, the minimum you should do is what I really should say, is a cancer screening on a 16-year-old. You should do one when they're 21 as well. But whenever you get older in your midlife, you should do them more often. And then maybe toward the end, less often. Because at that point, you're not really undergoing a whole lot of cell division. Well, you still are, your maintenance cell division, but you're not growing anymore, right? And if you have cancer, you probably already had it.
Mm-hmm.
It's kind of like the old argument for longevity, right? A person who's 16 years old is more likely to die suddenly than a person who's 85 years old. Why? Well, because statistically speaking, the person who's 85 years old has successfully lived for 85 years.
Yeah, that's right.
And I had a statistics professor explain that to me one day, the falsification of data through statistics. And we both know that an 85-year-old is much more likely to die suddenly, right?
Yeah.
But statistically speaking, when you're looking at just the math, the 85-year-old has, how many more times more experience of living life and not dying? And so statistically speaking, that person's less likely to die. It just happens. It has to do with past performance and longevity of the amount of time that the data is looked at. Not necessarily a great way to do it, but we should have some guidelines, I think, because I think a lot of people are very lost. I had a new patient exam. I did an oral cancer screening. That patient's been here for 15 years. Maybe you should do another one.
Yeah. Well,
it shouldn't just be a new patient exam.
That is a major problem.
I personally think new patient exam shouldn't be an actual word. It should just be comprehensive exam. And insurance should not limit you on a comprehensive exam to once per patient lifetime. Or if the patient has not been to the dentist for a year,
they have like a 3-year rule before you could, in other words, the patient is active for 3 years. If they haven't been in for 3 years, then they're active again.
Exactly.
It's like stupid because anything could happen in between.
Absolutely.
Like I'll ask a patient, and this is why medical history is not something you should forego, because I'm going to ask the audience, how do you remember everything a doctor told you last year when you went to him for your annual exam that you didn't give the dental practice that information? How do you know you didn't give it to them? How do you know you gave it to them? I never understood that concept. Like, how often do I have to have a patient fill out a medical history? Do you remember everything that happened in the last year?
Mm-hmm.
I don't.
So,
and not only do I not know.
That's why these things are so important, because these new health nets where you go in, your physician, it was kind of cool. The other day I went in, I don't even remember what I went in for. And they said, "Oh, Mr. Huffpower, and are you still taking such and such?" I was like, "I haven't filled out a medical history yet." "Oh, you're part of the such and such system, so we have all that information. Now we're going to need you to do an update, but I said, "Oh, cool. So I don't have to list all my medications and the milligram dosages." She said, "Oh no, we have all that in. I can import that. You won't have to fill that section out." So in a way, it makes things easier as patients.
Absolutely,
but it makes things much better for doctors.
Yes.
Not only that, but think about this. We know as dentists, people think we don't need to know those things, so they lie to us.
Well, not only do they lie, but they argue at you on why do they have to fill it out. Mm-hmm. And that's where the whole team comes in and has to. I tell them, our doctor is trained on oral and physical manifestations. He collaborates with the medical world. We collaborate with the medical billing. Because of that reason, we want to make sure that you are healthy here so that whatever's going on in your body doesn't manifest more. What do you mean? If I have to spend an hour with a patient, I will. That's my attitude, because they need to be treated as if they're at a doctor's office. When you go to a doctor's office...
But better.
Better.
But better.
Yes. You go to a doctor's office, you go in that room. I mean, think about it. When COVID came, I said to myself, why did they close us down? We're the most sterile practices in the country. Mm-hmm. And they needed us because it manifested in the oral cavity. Mm-hmm. Okay? So I have a problem with what they did there, but I'm a controversial person. I say it like it is. I don't care if you don't like it.
It's because you're from the Bronx, y'all.
Yes, I am from the Bronx, and we're very straightforward people. But the bottom line is, explain to your patient, we're here to help you stay healthier. That's our goal. That is our goal. And the Oral Systemic, I'm a founding member of that organization. I've been believing that forever because of my own daughter. And if you have a kid at home taking any kind of medication, there's a couple of things you should know. If they're being treated with attention deficit...
Any sympathetic mimetic, any of them.
Any of them, but attention deficit especially, they need a sleep apnea test. because they're being a lot of children are being misdiagnosed, and a lot of pediatric dentists that I'm working with are now doing this.
From siloing?
And they're moving out.
Well, because the pediatric specialist doesn't know what the pulmonologist knows.
Right?
The
but
pulmonologist
now they're moving.
knows that they share the same symptoms, but they're not taught that.
They're moving out. They're moving on.
I had one kid. Kid went suddenly, gained weight, went through puberty, gained a vast amount of weight, suddenly was getting sleepy in the early afternoon, was bedwetting, and their grades suffered.
Yep.
And the second they walked in, I was like, hey, we need to get your kid tested for childhood sleep apnea. I'm going to send you to a pulmonologist. They're going to look at you. I sent them to an adult pulmonologist. I didn't send them. They went to. I referred them to a childhood pulmonologist. They went to an adult pulmonologist and were told by the pulmonologist that children don't get obstructive sleep apnea. Came back, thought I was full of shit. So I did convince the mother to bring them to the childhood sleep apnea specialist, and they did have sleep apnea. And they recommended, I think very appropriately, diet and exercise first, before anything drastic. Because, I mean, a kid on a CPAP or a BiPAP, I can only even imagine.
Well, it doesn't work.
So, but the truth is there's so much siloing, and that was even within the same specialty.
Yeah.
I mean, an adult pulmonologist thinking children don't get sleep apnea? What the hell?
But,
it floors me. So I'm going to switch gears on you right now.
Okay.
Because I've got a lot of stuff I want to cover. And then I want to get to this continuing education event that you guys have coming up that you can talk a little bit about, and maybe some doctors out there will realize what a benefit you could be to their practices. So first question, how much money do you think that the average dental practice is losing every year due to billing errors? And the second part of that question, I'll tell you afterwards, because I know when I ask you the second part, you're going to forget the first part.
Okay. Well, the first part of losing money is thousands. And how you know it's thousands is the amount of times you get a letter back from the insurance company saying, we need more information. That you paid to send that claim through already. Mm-hmm. Now you have to redo it and resend it.
If you get paid.
And
you lost money there.
You lost money on top of the discount you're taking. So thousands. The other issue is looking at making sure that you put your fee in the lab part of your computer so that you can justify raising that fee to cover what it's costing you today to do the same treatment that you were paying $5 for way back when, because that is an important part of loss.
Right. Well, that also requires that people know their COGS. People don't know their cost of goods sold.
Well, they have to know the cost
they need
of
to
whatever they're doing.
If you own a business, you need to know the cost of goods sold.
Yeah.
I actually had a dentist tell me once that their CPA told them that dentistry doesn't have COGS. And I said, find a new CPA.
Yeah. That is something I've learned from bookkeepers and CPAs and all of that. And the third thing is, don't just quit an insurance company. Look at the write-offs of that company, because I was asked by a doctor in Ohio to come in and look, and he had a horrible airline actual clients, the pilots and the stewardesses. Right. And he said their hygiene money is horrible, da-da-da. But everyone, I said, did you look at what they're purchasing?
Does Delta Airline use Delta Insurance?
No, but that's a good one. But what they were doing was doing upgrades. Mm-hmm. They were paying for crowns and better. They wanted the zirconian or the made in the office crown. You could charge for that service.
You can also charge your lab fee out separately. People,
Right.
if you're doing gold crowns, sure, you're getting charged to do a gold crown, but you can include a materials fee cost in that bill, and that is legal. Legal. It's legal to make more money.
Yeah.
So it's unfortunately also legal to leave money on the table.
Right.
And that's my second half of the question.
Go
So the
ahead.
first answer was, how many practices are losing money by taking dental insurance? And the real answer is all of them.
All of
Because if
them.
you have ever had a denial, you have lost money. A very good indicator, if your collection rate is anything lower than 99%, or if you have an AR with anything outstanding that's past 60 days, you are losing money.
Yeah.
100%. So the second part of that question is, how much money are dental practices leaving on the table by not accepting medical insurance?
Thousands. Absolutely thousands. And this is the example that I use. I have practices that I've helped turn around because the patients would come in, they bought a CBCT scan, and so they're doing it for free. Well, you still have to pay that monthly payment. So to me, that's a foolish mistake. And I know doctors like their toys, but you can't guarantee that patient's going to do anything by giving them a free thing.
Mm-hmm.
You have to charge for what you do. It's actually a RICO law when you don't. What is a RICO law? It's the mafia law. And I know it
racketeering.
because I lived it.
I was going to say she knows it because, have we mentioned she's from Brooklyn?
No.
Or the Bronx, rather.
The Bronx.
But Brooklyn would count too, though.
Yeah, well, I worked a lot in Brooklyn and learned a lot there too. But you just really have to charge for what you do. No doctor has ever been asked, can you give me a discount? No medical doctor would even engage in that conversation. So stop giving discounts and start charging.
What would they do for cash pay patients?
Nothing. Nothing. Nothing.
I have seen MDs charge cash pay patients $5,000 for a delivery rather than the $50,000 or $75,000 the next person in line was getting charged. And that game is because they actually unbundle everything and they're charging you for every single Q-tip. They're charging you for every
But that's
breath air you
hospital.
take.
That's hospital.
Yeah, you know what I'm talking about. 'Cause
Yes.
The hospitals will do that.
The hospitals will do that. The hospitals will send you a doctor that you don't really need and doesn't know you, and then all of a sudden you get a bill for that. Yes, I know.
But the hospitals will negotiate and they'll say, oh, if we don't have to file insurance,
Yeah.
it's only $5,000. You file insurance, we'll find out how much it is after we bill them.
Yeah, they don't pre-authorize anything. They will make sure that, like if you're going in for surgery, like Paul went in for emergency surgery, they don't have time to do that. There's a 10-hour call for open heart surgery. That's not going to happen. They know how to document. If you have an emergency patient, you can't stop to call an insurance company to get a CBCT scan. You got to do these things in a line item, but stop giving away services. And there is a website that I'm going to give out.
Fair Health?
Yes, I've been using it forever. fairhealth.org. Okay? Go to the organization. Look at your dental codes and then move the code over to the medical, and you're going to be able to pick the higher fee on certain products that you're going to be billing to medical, because you can't have two fee schedules.
That does raise another question. I'll ask it after this. But what procedures are most commonly underpaid or unpaid because of lack of documentation?
Well, nowadays in dental, they're asking for more medical documentation. So I'm seeing thousands of claims. I mean, we're only at the beginning of January, and I'm getting calls from offices saying, why are we getting denials on hygiene? The hygienists don't document correctly either. So nobody documents the right way. And I told you this, NYU, when I taught there, they wrote a book. They write a text message. This is a bad problem in our industry.
Absolutely.
Documentation is the key to getting paid the first time you bill.
So how often would you say dental practices give insurance companies discounts without realizing it?
The insurance company?
Now, how often do dentists give discounts to the insurance company without realizing it?
Well, I'm going to tell you that.
Plan.
That plan always has a copayment.
Mm-hmm.
If the patient is not paying a copayment,
well, you're going to jail for that.
You're going to go to jail. That's number one. And you're actually losing money on a patient. Why would you give an insurance patient a discount? That's my question to every doctor. If they are dealing with an insurance, they're getting a discount.
I would say that many dentists actually give the dental insurance companies a discount. So what I've found through DIVA, which is Dental Insurance Verification Automation, this is the company I was telling you about, what we have found is that it's very often, because we have thousands of dental practices. We're out over a bunch of DSOs, and we're just finally actually tailoring this for private practice. And so we know what the fee schedules are, because we know what people got paid and we know what got denied. And so we can reverse the math on that and say, okay, the sweet spot is right here. This is how much they'll pay for that on a MAC.
Right.
Unfortunately, dentists generally don't have that data in front of them. I would say most dentists are giving dental insurance plans additional discounts above and beyond the discount
they
agreed to on the contract, because they don't know how much they can charge, so they don't raise their UCR so that 60 or 80% is
But talking about UCR and raising, you should not go and just do 20 codes and make them more money. That's like a ridiculous way of doing it. You really should have somebody that specializes in helping you get to what you just said. Where is the fee lay now? Have you upgraded your contract?
Mm-hmm.
And if you think it's like the old days where your office manager could do this, those days are over. You have to have a group that has connections into the field, because you're not going to get anywhere.
And no, before you ask, it still won't work with Delta.
No.
Well, Delta does not negotiate with dentists or terrorists or something like that.
Yeah. But no, I mean, I've seen some negotiation. It's according to where Delta is.
Mm-hmm.
But I could tell you that if you try to do it, you're getting nowhere. But you can advise a company, like, this is where I'd like to be, and they can help you understand whether you can or can't do that and why. It doesn't matter if you raise all your fees.
I'm gonna make a side bet with you here. I want you to pull some data for me.
Okay.
I'm gonna bet you $20 that any Delta Dental insurance, Delta Dental, any of them that have ever negotiated with a doctor, they are in a state with a very sparse population.
Yeah.
I almost guarantee it, because they're required to have a certain number of providers per population to actually offer dental insurance in a place. And that's the only place where they're actually scared of getting under that number, is when the population's extremely sparse. And so there's not enough dentists who take their plan, because as we both know, rural dentists are much more likely to not be in network.
Right.
So I would be willing to bet you. I'm gonna bet you $20.
Okay, I'm
so
gonna
give me a call
I'm gonna
back.
look
You
into
can find
it.
one instance of Delta Dental negotiating up on their fees that's not in a sparsely
Okay.
populated state.
Well, I can tell you this year you're probably 100% right, because every plan is lowering their fees. And they do it as a group, which is not allowed, but they do it.
Oh, it is allowed for them. Not
For them,
us.
but not for us. And
I thought we just passed a law to fix that.
That's why I can't give you a fee to charge, but I can direct you to go to fairhealth.org, because patients use it.
Mm-hmm.
And I have learned to use that when I was treatment planning.
Yep.
because they have to understand patients. They're always going to ask for a discount because we spoil them.
Mm-hmm.
They're always going to ask us to do all the work because we spoil them. And you can change that. Like a patient today with medical has a box with a code, and they could go in and see everything. I, as a practitioner, can't do that. So what do I ask? What is your code? Can I go on it to help you get your benefits? They give more information to a member than they ever will to us.
Absolutely. Particularly if you're out of network. They don't want to give you anything.
No.
But guess what? Diva's building a blue book. So we're actually creating a complete price list of the actual fees every year.
Mm-hmm.
And we're not ready to offer that product yet. We're still beta testing it internally because we want to make sure that our prices are correct. But yeah, the dental insurance companies aren't like that much.
No, but the medical plans are getting harder too. That's why I wrote the letter. But patients have more access. So if they want my help, I ask, did you sign up for your chart? Because in that chart are your benefits.
Mm-hmm.
And they list codes. Now, at one point, I was able to pull up on Google any insurance company and their codes that they pay, dental, medical, the whole 9 yards. And if you look that up, you can still get some of them to give you that.
Mm-hmm.
But you have to look up the medical because some things are not covered under dental, and you are entitled by law to bill medical. And this is a fallacy when dentists say to me, well, it's illegal. No, it's not.
No, double billing is illegal. Getting paid
More than your fee.
Exactly.
It's illegal.
It's illegal to bill medical insurance for the same procedure and the same total price as to bill dental. You can't double dip. But what you can do is you can, ameliorate some of those losses that you incurred for being in network with an insurance. Let's say you had a 40 or 50% write-off, which is not uncommon these days. By the way, your profit margin is generally only 30%. So if you got a 40 or 50% write-off, that's another indication that you're losing money. But if you've got a 50% write-off and they have a secondary dental insurance, you bill that for the remainder, and whatever portion is remaining from that, you could then bill to medical, as long as you're not billing out over 100%.
Right. Well, this is really how I teach it, because people ask me all the time, do I bill medical or do I bill dental?
Bill medical first?
So medical should be billed first.
Yeah.
This is why. Because the first time you bill them, you're billing the exam, the CBCT scan, oral DNA, whatever, okay? That's going to go towards the deductible, right? You could still bill that to the dental because you didn't collect anything.
Mm-hmm.
Actually, the patient had to pay, technically, out of the deductible. So you could still bill their dental. You are allowed to put the two together. So, for instance, a bone graft fee is $1,000 in my office.
Mm-hmm.
$800 is paid by the medical. I could still bill the dental. I still have to only collect $200. Not that they pay it, but I can. But I bill both.
Mm-hmm.
The difference is if you're in network, you don't want to bill the dental first because now you're stuck with those fees.
Right.
The point is to bill medical first and get the higher fee. And let me tell you, the deductible is less out of pocket for the patient and not the patient, for you, than you would be doing if you only bill dental. Think about how much you're losing billing dental. That 40%?
Yep.
The patient is better off paying $3,000, $5,000, because if the case is $40,000, what are you going to collect from dental? $1,500?
Mm-hmm.
That's why they deny treatment.
Yep.
They can't afford it.
So let's get into some of the nitty gritty here. Okay, let's say I have a patient who comes in. They need all on four. Our treatment plan is all on 4. Okay. They have medical insurance. Mm-hmm. They have a primary dental insurance. Mm-hmm. And they have a secondary dental insurance.
Okay.
They're divorced, but remarried.
Okay.
Their husband's birthday is before their birthday. 9 out of 10 dentists are completely lost right now about why I just asked all those questions or gave you all that information. Mm-hmm. Break that down for us. Tell them why all those things are important, because I think that'll give people an idea of how much they don't know about dental insurance. And
even medical insurance has the same ruling, but medical has changed. Every patient gets their own medical card, period, their own number. A baby gets a number after a month old. The minute they get Social Security number, they get a medical card under that Social Security number. Where dental is like a family plan and everybody's on the same thing. So the deductible is a family deductible. You could have a family deductible on medical, but if the age of the father is older than the mother...
The birthday rule, by the way, guys.
The birthday rule comes into play. If they're divorced, I don't get into that. I just refuse because I don't care what lawyers say.
So that part doesn't matter unless you have kids. If there is a dependent, then it also depends on the state, and that depends on who was awarded primary custody to determine which birthday rule goes into effect.
Yeah.
Enjoy, guys. It gets complicated.
It's very complicated, and this was my...
Is that correct? As I recall, that's about how it works.
Close to it. Most offices that are dealing with that issue, I recommend that you tell them that you have to pay us in full, and when you could submit your plans.
We will reimburse you for anything that they pay us.
Anything that was overcharged, we'll give you back, because I'm not going to play that game. It's too hard. There's medical, there's dental, then you have lawyers in the middle who don't speak English. Mm-hmm. They don't speak English because they're protecting their client. And you can't make that decision for them. So I would charge full fee and reimburse them if there was an overpayment.
Okay, now this gets into I think a very pertinent argument and a pertinent discussion. Okay, this is our implant. All right. Our same argument. We've got our bone graft, got our implant, we've got our crown, right? So obviously, you get your patient coming in, they say, I need an implant. You look at them, you say, you're right, an implant will work here. I think that's the best treatment. Let's go ahead and do an implant. So your price for an endosseous implant is, let's say you're a cheapo and your price is $1,500 for the implant. Okay, we're not going to talk about the bone graft, not going to talk about the crown here. And the reason we're doing that is because medical insurance can pay for implants. Okay, so I've got this $1,500 I usually charge dental, but now I'm in a new world. I'm charging medical first. How much, just an idea, okay? How much should I be charging for that implant? And I know a lot of people are going to say, oh, you can't charge people differently because of insurance. But what you're looking at here is not charging two patients a different thing because one has insurance and one doesn't. You're talking about how do you arbitrage the loss of being in network with the dental insurance by charging the medical insurance and then using the dental insurance as your secondary, and if they have a secondary, as the tertiary. So walk us through that. I know it's a complex
Yeah, it is.
question.
And first of all, I'm just going to say straight out that one single implant may not get covered because what they'll cover more are the patients that have a medical condition. And I myself lost teeth because of a medical condition, but still didn't have things done at the right time. Even though I teach it, I'm afraid of it. So saying that, the longer it goes by, the harder it is to do, right? But let's just play a scenario. First of all, my implant fees are according to the zip code you're in and the fee schedule that's on fairhealth.org is anywhere between $3,000 to $5,000 just for the implant. The bone graft is anywhere from $1,000 to $3,000 according to the area. So when we're looking at that, just that one single thing, there goes the deductible.
Mm-hmm.
Okay? Now, crowns are not covered under medical, but the material and the lab work that goes back and forth is covered.
Mm-hmm.
So, say, for instance, you have to ship something to a lab. Like I do this for oral DNA all the time. That shipping cost from my office to oral DNA for them to do the test is covered by medical. So that's why when you get a bill from the lab is when you bill that lab work. And that's why that lab work is tracked by medical.
Not on day of service.
No.
On day you receive the invoice.
That's and by the way, if it's a lab work that's diagnostic, you want to wait for that test result.
Right.
Because that helps you even more. So that lab work all of it should be in there. Whatever kind of bone, whatever implant you use. The way you have to track an implant in dental is that way.
Scan your implants into your computers.
Yeah.
There's nothing more frustrating than being a person who is freaking restoring an implant. The original dentist that placed it 5 years ago has no idea what the hell kind of implant it is. Please scan your stuff into the computer. Okay, that was my 2 cents.
And think about it as documentation. I mean, a doctor, I work for the spine surgeon. We put rods in kids that were, scoliosis. They were labeled, engraved,
mm-hmm.
because they were going to grow and be removed.
Mm-hmm.
That was the point. So everything is documentation from them.
Right.
And medical billing, I try to advise doctors from the beginning. Don't be trying to put every implant in when there's an extraction or one implant missing, because it's just a waste of your time.
Mm-hmm.
Not going to happen. But the people that need it, that have a medical necessity, even the single implant, will get covered.
Okay, so let's jump back though. So I've got an implant. I have medical insurance.
Mm-hmm.
I've got dental insurance, and I have a secondary dental insurance. When I'm looking at my implant, let's say it's very competitive where I am. I'm charging $1,500 for an implant body.
Okay.
All right. So I know medical pays a heck of a lot more than dental does for implants.
Mm-hmm.
I've experienced it. So first of all, is there a problem if I have a price for medical and a price for dental?
Yes, you can't have two fee schedules.
So you have to have one fee schedule. Where would you recommend I set that fee schedule? Not an exact number, but we know dental pays a lot less
than medical.
Yes,
absolutely.
So a multiple would be a useful answer. That way you're not colluding.
Yeah. When you're doing one implant, that's a lot less work, right?
Mm-hmm.
If you're doing a case with an overdenture, that's a different scenario.
That's my perfect day. What are you talking about?
Of course. So, according to how many implants, now they're raising it from 4 to 6.
Starting whenever I began doing implants, whenever you met me, I've been doing 6 upper, 6 lower.
Yeah, and that is
Belt
the recommendation today in today's world. But so say 12 implants now, okay? Mm-hmm. That's a case of a sick person, period. You can't look at it as, oh, well, I never replaced this tooth when I had it extracted. They don't even remember. When you are placing implants, you have to tell them, how did they lose their teeth?
Mm-hmm.
how much atrophy is there. They're not going to meet those qualifications if they're not sick and they just extracted that one caries lesion tooth. But we're talking $80,000 for 6-on-6 between the implants, the bone grafting, whatever one you use, and then the overdenture.
The question I was really getting to is a question of strategy.
Yeah, bill medical first.
Yes, bill medical first. But when you're looking at your prices, knowing that medical insurance will pay you more than dental insurance, one of the things that may really behoove you is to go into your UCR and say, look, what is medical going to pay us? Dental insurance is only going to pay you a little bit, right? So I would set my prices for what the expectation for medical to pay is.
Yes.
And then you use your primary dental as your secondary insurance, the way that we're used to in dentistry. And then you've got your tertiary for any, sloppy mop up afterwards.
Yes.
But the important point here is that you need to consider that the medical insurance will pay more than the dental. The issue that people get into there, and what I was trying to get to, was that people were worried about the differences in pricing for cash patients versus insurance patients.
Okay, let's just go back to one step. Medical is going to pay at a higher rate. So why would you keep the lower rate? Because if you're doing the single ink crown, and they're dental and they're in network, you're only going to get what you're going to get. It doesn't matter what your fee is. So at that point, you're writing off, right? But if you're billing medical and they didn't say they paid for the bone grafting, they'll pay some money towards the other stuff that you're doing, maybe avoplasty or whatever. But dental's paying the implant. They're not going to go. It doesn't matter what you bill them. So always keep your fees higher because dental in network is not paying any more. And if say you're not in dental network, but you're billing medical first and they didn't cover one of the things that you're billing, you could still bill dental at your full fee. They're going to only pay what they're going to pay. So your fees being raised, and if there's no medical and your fees are higher, you could always give a cash discount to a patient.
So you cannot
for full
give
payment
a cash discount to every patient.
No.
That is a cash-only patient. I was actually trying to loop back to something I did that you had mentioned earlier, DSPs, dental savings plans. So guys, here's the deal. If you have a cash patient, and let's just throw a big number out there. Let's say $8,000 is the price per implant for my medical. So I'm going to set my price at $8,000 per implant. So cash patient comes in and says, hey doc, I really need an implant, just a single tooth implant. And you proudly say, hey, our implants are great. That'll be a total of $15,000 with the implant, the bone graft, and the crown. And the patient dies right there.
Yeah.
So what you can do legally is you can make a dental savings plan.
Yes.
And then you can say, only members of our dental savings plan get this special deal. You see this beautiful implant? Usually $10,000. Now just for you, because you have a dental savings plan, only $1,500. That's right, because you have a dental savings plan. It's not discrimination against people who have or don't have insurance then, because you have added another entity, which is a dental savings plan. You have a membership plan. That membership allows you to completely bypass that issue and that worry about having two separate fee states. You don't. You simply have a discount for people who have your dental savings plan.
Right.
And that helps you to skirt that legal issue, that legal hairpin
I'm a
turn.
big believer in that, and I'll tell you why. If we were doing an implant case, and I tell this to every office, so I'm going to say it, how did they get that way? It's usually perio. It's usually some form of infection. Why do people think the minute they have bone grafting and implants that's forever? That you still need perio. believe it or not. So, because one of the big things we've learned in the last few years is the loss of implants due to Periodontititis. So we have to address that before we start treatment. I add into all my treatment plans 4 cleanings a year. And my payment arrangement plan, my savings plan, had them all covered.
But it's definitely an interesting legal thought. It's what we used in my practice. I've consulted with attorneys in Texas. When I was practicing, this was legal. I highly suggest anybody who is wanting to do this and wanting to begin doing medical billing that they actually run this by their attorney and say, is this legal in my state?
What, the medical billing?
No, doing
the membership plan.
Because you want to make sure that
don't do your own. Please don't think you're going to save money. We used a product for years in our practice, a reputable company that I use all the time. And we even made money during COVID in the 2 years because patients would get those checks and send us our money.
It's the gym membership.
Yeah.
Man.
So, and it's set up where we're not responsible. The company sets it up where they collect those credit cards and all that stuff. I don't have anything to do with it. It's automatic. It was a beautiful thing. And I recommend it for every office because some of these cases, even with medical billing, they still require follow-ups. They still require perio. Let them know that in the beginning and give them a membership plan to follow through on. Because implant cleanings are very rarely covered under dental when it's an all-on-6.
So verbiage is also very important. One of the things that we did is we would actually add the dental savings plan to every treatment plan for a new patient.
Yeah.
And we would explain, hey, this dental savings plan, we had a breakdown. So one of the worst things that you can do is hand a patient a printout of
Chinese menu.
Because it's just like a Chinese menu. They're like, yeah, I'll take one of these, but I don't want any wonton soup today.
Yeah.
No, you don't get that choice. This is part of the bento box, right? So what you do is you give them a financial statement that says, here's what we're doing. These are the things we're accomplishing. And here's how much it costs, bottom line. Under that, I always would give them the treatment plan. I'd say, look, I know these are a bunch of numbers and they're really kind of confusing, but I want you to know what you're getting. All of these things are necessary to do this. The dental savings plan you may notice on there is because the dental savings plan costs $365 a year, which is $1 a day. But because of the fact that it gives you a 15% discount on this, and this, you'll see on this column right here that your price is this with the dental savings plan and it's this without it. So if you don't want the dental savings plan, you can check this box to refuse it, but then this will be another $2,000. Guess what? Who's not going to not take the dental savings plan? And it has to do with the way you present it, guys. It's important. You just tell people prices and you give them a menu of stuff that they're getting, they're going to start trying to take things off. If instead you give them a menu of choices and you say, because I've already made this choice for you, you're going to save $2,000. If you'd rather not make that choice, you can go ahead and give me $2,000 more. Guess what they're going to do every single time? And then that patient is now cemented to your practice. It's the reason we had 95% of our patients who are not insurance on dental savings plans, which is high for most offices. But the other thing you have to do is you have to make sure in the verbiage of your dental savings plan, it says that if you have insurance, you are not eligible to also participate in the dental savings plan. And after you do all that, things become very easy. And you make a lot more money and you get to do the treatments your patients need.
Yeah. And it becomes their policy, so to speak, to have that dental treatment.
Now, my next question is going to go into our next segment, and it's going to kind of bridge the two. Our next segment is going to be audits, liability, and consequences. I know you love that part.
I do.
So the question that's going to bring us there is, what is the difference between aggressive and accurate billing?
Accurate billing is the difference between the education and the knowledge of every person in that practice, knowing what to document. Because a good biller will look at the documentation before the codes and say, this doesn't say what he did or she did. And that is where the difference is, because I would see doctors come to the girl up front and say, I just treatment planned 3 implants and crowns and bone grafts and, give her a treatment plan. No, that's not how it works. That makes aggressive billing. There's a little chance of getting caught in aggressive billing, even if you think you're billing the right things, because you don't understand what's needed. That's where I see the big fault in dentistry today. We're not used to documenting. There's companies that want your notes from the computer. They won't even take a letter after. Years ago, dental would take a letter you write afterwards. That was aggressive billing, because we didn't have those notes. That was actually wrong and illegal to do, because you made up notes. So they want your notes, and that's how medical works. They want your notes. And if I don't have the notes, nobody could bill for you without it. I don't care what billing company you work with. If they're not asking you for a copy of your notes and a copy of your fee schedule and a copy of the SOAP note on top of anything else, they're not doing the right thing, and the patient's medical history. Because we still need to put, Mary is getting 12 implants. First we're doing bone grafts, all 4 quadrants, however you're going to do it. Then I'm going to go to the implant 6 months later. After the bone heals, I'm going to place the implants. But you're presenting a case, not first we do this, then you heal, and then you come back in and get this done. No, it doesn't work that way. It is a full case. Like TMD is a full case. Sleep apnea is a full case. We're obligated to see those patients after the appliance, even though we can't bill for it.
Absolutely. And so that's the, well, we'll talk about office visits later. But here's the Cliff's Notes version, guys. Tell a story, don't bill procedures. It's as simple as that. The story is, patient came in. They had some messed up things going with their mouth. They need a bunch of work. We're going to fix that.
And if you have a great person taking those phone calls, and I've been advising people to use a virtual assistant who could concentrate on that call and call back anybody she missed, because the front desk is rushing through it. They're busy. They're checking out somebody. They're checking in somebody. They're trying to get insurance information. It's craziness. Do it calmly. Patients fill out all their paperwork online. This virtual assistant could then take that information, make sure we have all the right information before it's sent to the office. And on top of it, they can pre-authorize, pre-verify, and do all of the things necessary that could have the patient have an appointment. I actually learned this when I moved to Florida. No doctor will see you in his office without all of that paperwork. But when you walk in to his office or her office, they greet you by name. They know all about you. So you go into their operatory, you sit on that table, and he goes, "Oh, Christine, nice to meet you. I've gone over your medical history. I know what you're taking already. I know what your issues are. I know that you feel like you want to lose weight, but you simply can't, that you have a little high sugar, but not too bad. You know, they talk to you as if they've seen you 10 times. Mm-hmm. Why? Because they do know you by your paperwork. That's an advantage, that patient now is relaxed, not holding on, because this doctor knows about her, knows her likes, her dislikes. Fear is a big motivator in not having treatment done. How do we dissipate that?
Finances and time.
Yeah.
Those are the three major roadblocks to treatment.
And that's how we can engage a patient before they even come in.
Absolutely. So one of the things I'd recommend there, you can put things on your
website.
Well,
they
you
download
can
it.
Put things on your new patient forms.
Yeah.
One of the things that we actually put is an amenities section. And we put down, when you come in for a visit, would you like cold water or room temperature water? Would you like a blanket to be present in the room? Do you get cold often? And one of the things there is that also points you to other stuff like, do they get cold often? Do they have poor circulatory issues? Mm-hmm. Is that a question I need to ask a follow-up on? Or is this just a person who has, internal thermostat that's a little wonky like mine is? But all of those things, when you read the paperwork, don't just collect the information, digest the information. When you look through that paperwork and that patient comes in and you've got a room temperature water and your assistant says, if I remember correctly, you like room temperature water because you said you have a little bit of sensitivity. So here you go, Miss Smith. You said you sometimes like a blanket. I've got the blanket here. Is the temperature all right, or would you like me to get that for you? You do that, and all of a sudden those patients, 95% of them, are doing whatever the hell you tell them to do whenever it comes to treating their mouth.
And I just want to bring out a point about an assistant. They are underutilized. They are the moms of the practice. They're the people that comfort the patient the best and doesn't have a label on her. Like the front desk has a label. It's a $. They know it already when they walk in. That the assistant in today's dentistry could do so much more. And more states are having them get more education.
Yeah, your expanded stuff is pretty cool. I don't think they'll do that in Texas until everyone.
I think that you're going to see a need, because I can tell you
the need's there.
The state of California just changed all their laws again to meet the needs of the doctors, because the hygienists were charging $100 an hour. Mm-hmm. Now, we all know $100 an hour for a hygienist, if you're on insurance, is a big losing ticket here. It's impossible. So they were quitting, and they're what are they doing? They're not stupid. They were traveling, so they're making more traveling as a hygienist. And they're doing myofunctional, which, by the way, still needs a doctor.
Absolutely does.
And they want to do it on their own. And speech is not part of it, because there are speech specialists for children. So is that an issue? To me, it is. But myofunctional has to be done in the office. It's not a side job. You would think hygienists would have learned that when they first started opening their own practices, but now they're looking for $100 an hour. It's impossible to keep up with that. So the state of California actually left the hygiene program and the assistant program and put in their own rules and regulations on enhanced assisting, where they could do more, including profis. They have extended a hygiene license to graduating dentists, because they don't get their license for a couple of months. And then if you have to put them in a plan to be able to do in-network stuff, that takes 6 months.
Well, there's not a lot of laws that come out of California that I'm in favor of. But
I know, but these are really good. So they're hiring young dentists who need money, because let's face it, dental school now is anywhere between $80,000 to $150,000. Easy.
Well, it also helps because, so let's say you've got I'm not suggesting this to anyone, but it's just something that occurred to me. Let's say you have a dentist who comes in, they're a new grad dentist, they're trying to build a patient base. They are doing mainly hygiene and new patient exams so that they can do that, which, by the way, guys, stop complaining about that. Be happy you have a job. They're tight. If they have a hygiene license, then you could legally separate. I mean, you can legally do it anyway, but it's questionable.
Well, they have to pass as hygiene.
Right. So you can get them paid as hygiene for the cleanings, as a doctor for the exams if they've got both licenses, because you can split that compensation up. That'll be more fair to the associates and also allow them to
increase
allow owners to right. So I think that's a really good idea.
Yeah, and then
after do need to move on.
The minute they get their regular license, then those patients become their
absolutely. So, what triggers audits more often than dentists realize?
Audits are triggered by, there are companies that scrub claims after they've been paid, and they have a system. They know more about every dentist than the dentist himself knows. They know how many endos you did, and unless you're an endodontist, they want to know why you're doing that many. They look at...
And you receive a letter from the insurance company that says, we noticed that you do more crowns than a dentist next to you.
Yes, that's what they do.
That doesn't mean you're doing anything wrong, by the way.
No, but they are looking at everything. Absolutely. And that's what triggers audits. In other words, I have a doctor who, in Brooklyn, who was only doing scaling and root planings. That's like almost impossible on a GP practice. I'm not saying it. Yeah. You have all age groups. So you have to consider that they're going to say, why is everybody scaling and root planing? Don't you have any 14-year-olds? Do you have, not that they might not need a scaling, but it's just not normal to not have prophies or perio maintenance, just scaling and root planing and scaling and root planing. Well, he got audited, and they found that he changed the codes from the hygienist to what he wanted to get paid.
Don't do that.
No, don't do that.
So what are the worst mistakes that practices make right after receiving an audit letter?
Don't call them yourself. Don't ask for why. Get a lawyer first, a good, reputable lawyer that works in dentistry to give you advice. The minute they ask you to send them 15 charts to look at, know that they already know that you need to be audited. And they want money back. That's just the fact. So the fact that they have companies doing this now is making audits more feasible to collect money back for work that they feel was aggressively billed and not exactly billed.
How often do doctors, trying to act in good faith, accidentally incriminate themselves during audits?
Yes, that's a very big mistake. And I'm going to
Same thing with police, by the way.
Yeah.
You have a right to remain silent.
And you should remain silent. Yeah, absolutely. Don't get on the phone with anybody. Don't give advice. Don't tell them it was a mistake. Don't talk to these people. You have to have a good attorney.
And don't let your team talk to them.
No. And by the way, teams are not supposed to talk. The front is not supposed to talk about anything medical. And if they're asked about chart notes or whatever, they need to take information down and pass it off. Not talk to any insurance company about a patient.
Where does the legal responsibility lie when billing is done incorrectly, even if the dentist doing the treatment didn't submit the claim?
Always the dentist. Actually, even your computer signature on file is legal. So you're going to be the one to get in trouble. It doesn't matter who did it. What matters is having them trained to do it and making sure they're not doing it. Because if there's that many audits, there's also fraud.
Yep. What documentation mistake turns manageable audit into a disaster?
Billing for a product that is normally used only for a cancer patient or without a cancer diagnosis, or billing for, I could tell you billing more for fillings that aren't really there and they had a filling by another dentist somewhere. They track everything. They track everything. Like they grade you. A, B, C, D, and F.
But there's so many legitimate ways to make money in dentistry. It floors me that anyone commits fraud.
I think some of the time, I mean, there is one office that the hygienist got committed with fraud over the doctor, but he ended up suing her on top of it.
I think they need to start being held responsible
for what they do. Yes.
If they don't do a scaling and root planing, well, again, that comes down to the doctor's diagnosis.
It's really the doctor that has to.
It's gotta
but the problem is, and this is where the problem lies, and why are doctors held responsible? They're supposed to be overseeing hygiene.
Right, but if they're opening their own practices, there needs to be some way of offloading the liability.
Yeah, they have to have liability insurance. And that is a problem because a lot of...
even opening them when they can't diagnose. They can't diagnose someone.
No, you still need a dentist.
Yeah.
They can only do the prophy cleaning referral, whatever.
Yeah. We have to do something with that because there's definitely some times where I think there's some liability that goes on the dental hygienist.
Absolutely.
But I have very rarely seen a lawsuit against the dental hygienist.
Well, because they're not the ones held responsible. The doctor is supposed to be diagnosing.
Yeah.
But there is a lawsuit that just passed where the hygienist got sued also because the patient, listen to this, always had scaling and replaning. And she said to the hygienist, I can't afford it this time. So can you just do a prophy? Well, she didn't say prophy. She said cleaning. Okay. The hygienist went ahead and did the scaling. She said, oh, I know you. You've been a patient for so long. I'm going to do the scaling. That's the patient that sued her. She said, I told you not to do it. And she did it without a signed consent form.
Yep.
But the doctor then in turn sued her for monies and treatment that she did that was illegal. And the judge said to him, this was interesting, he said, you're supposed to be overseeing this. Why did it take a patient to sue for you to find out?
Because we don't look. Okay, so when you are going to be going to Ms. Taxin's amazing CE. I've been to it. It was one of the things that really helped me in my fee-for-service practice as a scratch startup. And in fact, sometimes whenever I see that she's lecturing somewhere, I will go, I think I did this.
Yeah, you did.
I will go and I will ask smart-ass questions from the very back of the room. I try to hide so she doesn't know who it is, but she always figures out who it was. But it's a lot of fun. But when you do go there, you're going to cover PPO versus fee-for-service reality checks, leadership and ownership, future of billing. You guys are going to cover a whole lot of different things.
Oh, yeah.
We just don't have time to get into them on this podcast. But for the last portion of my interview, before we talk about your CE and how they can get a hold of you and get training, I'm going to give you some rapid fire questions. I want these. Now, okay, here's my challenge to you, Christine.
One word?
5-word max.
Okay.
Because I'm being nice to you.
Okay.
You know it's usually one. Okay. Most misunderstood billing concept. I'm counting.
Oh God.
Oh God, that was 2.
The order of the codes on the claim form.
Order of codes on claim form. That was 6.
Okay.
We're going to give that one to you. Most overused excuse dentists give.
On billing? They don't know it. That's just a fact. They have no idea.
It's true, too. They don't know it. Okay, we're good. It was 4. You know, those balance out. You get 5 now for each one. One document every office should review tomorrow.
Any contract you signed with any insurance company needs to be read by a lawyer, and then you want a new one if you're going to stay in network.
I only have one question left. How are you going to make up all those words? Okay. One sentence every dentist should remember about insurance.
It's not about the profit or the amount of patients. It's about what your recommendation is for the patient. I'm sorry, that was more words, but
All right. You ready?
Mm-hmm.
It's going to be more words, but this is the sentence I used, and I've already said it once. Dental insurance is a mechanism of payment, not a mechanism of diagnosis.
Right.
And you all need to remember that. Christine, thank you so much for coming on the podcast. Before we close everything up, can you talk to people about how they can get in touch with you if they want training? Maybe tell them a little bit about your billing company. And also, you guys have a continuing education class that you're putting on very soon here.
Yep.
TBOD members have a special discount code
Yes.
on TBOD right now for that. And I will post that under a clip of this on TBOD so that people will know how to sign up. But if there's anyone out there who's not a member of the Business of Dentistry Facebook group and they are listening to this podcast, how can they get in touch with you?
Well, they could get in touch with me by phone, 914-450.
Talking to the microphone.
914-450-2906. My email, it's a long email.
Yeah.
So it's
Well, just give the company name.
my company name that you want to contact me through is gentlemedicalbilling.com. There, everything is there. I have a membership program, which I advise people to do after they've started, because that gives them free webinars, educational webinars. We do one almost every other month. I have on other educators also to bring in other information. I do 2-day hands-on medical billing courses, and then you get a month of training afterwards, and then join the membership, and you get more, because things change faster than I could keep up, and I try to keep up. The 2-day hands-on is the best way to learn medical billing. You bring your own chart. You get to learn how to tell the story from what you've written in your chart. So you're doing your own billing and learning at the same time, and that brings a different perspective to it. And then I'll check every claim. We walk around. I teach you how to fill out the form. In fact, I send that to you in advance of the meeting as a webinar with all the directions so that you can have it on your computer. And when after this medical meeting, you can really utilize that. And don't think that I know every code, because I don't. It's impossible. I will say to you, don't think it's like way back when you started, where there were not that many codes and you never needed diagnosing. The things you have to remember are not codes. The scenarios, they're the stories, and the reason you're doing it is for the patient's benefit.
Do you still give that really handy cheat sheet out?
Oh, I give out a lot, yeah.
That's fantastic. So if you go to the CE, you will receive this wonderful packet where there's kind of the dummy's guide for medical billing. It's like the most common things that we encounter in practice, and the most common narratives that treatment takes. And by narratives, I don't mean the narrative you send into your insurance, but rather what's the story behind the patient, behind how they came to need this treatment, why you've decided to do the treatment, and what treatment that is.
And a lot of things I use now are pictures. Patients do not respond to our long-winded conversation. They respond better when they could see something. So when I teach, even at the implant meeting, I used pictures. What does a patient say when they open their, like, what do you say when the patient says, I have burning mouth? People have burning mouth syndrome.
Mm-hmm.
There are codes for these things.
Absolutely.
Diagnostic coding. You don't get burning mouth syndrome because you're healthy. You get burning mouth syndrome because something's going on, just like the bleeding. One sign of bleeding is an infection. If you cut your leg, you would go and clean it, antibiotic, and if it's still bleeding, you're going to go to the hospital and have it looked at. Why is bleeding in the mouth normal to people? Like, that is something I don't know. Oh, it's normal for me to bleed in the morning when I brush my teeth. No, it's not. Not normal. So pictures do tell a lot of the story. When you're telling a patient, it's faster, it's more understanding, and it's easier, even for the person trying to explain it.
Absolutely. Well, guys, thank you so much for joining us for this podcast. I hope that you've gotten some information that makes you really think about, maybe I should take medical insurance. Whether you do or not, you definitely need to take this course, and you need to bring your team, and you need to go. It can't just be your team. Because remember, whenever the compliance with billing falls down and people get into legal trouble, people are called you. Mm-hmm. And that's it.
Can I just say one more thing about the meeting, please?
Yes. This
2-day extravaganza is called for ROI. I have a lawyer speaking that I've worked with who's excellent. I have dental coders teaching. I have hygiene coders teaching. I have medical billers coders. And then we have ROI and people that work with the codes and the fee raising that are professional at what they do. So it's not just the coding. It's how to run your practice and make more money in general. And it's also about the compliance we're under and all the laws. And I could tell you last year, the lawyer, he got, I don't know how many people circling him at the end of the day. And I said, that's it. From now on, once a year, I'm having a lawyer speak at my meeting that does dental information. And she was a dentist, a surgeon, and now a lawyer. So her background is pretty amazing.
Absolutely. Well, guys, thanks again for joining us. We'll catch you on the flip side.
Switch that V6 for the EV, ride around my city. You should come right with me, yeah.